morning, afternoon, and evening, everyone. Welcome to the End Brain Cancer Initiative's annual May Know All Your GBM Treatment Options webinar. Today is May 16th, 2025, which is shocking. Thank you for joining us. Today we have people joining us actually from all over the world. Pakistan and United Kingdom, Australia, India, Saudi Arabia, Canada, South Africa, of course, also from the United States, everywhere, Texas, Virginia, Wyoming, Illinois, California, Maryland, just from everywhere. So this is great. We have over 100 people registered today, and we're super excited to bring to patients, families, researchers, scientists, neurosurgeons, neuro-oncologists, nurses, all healthcare providers, advocacy, pharma device, diagnostic companies. We're excited to bring this program to you today. So thank you so much for tuning in. I am Dellanne Elliott Midland. I'm the president and CEO of the End Brain Cancer Initiative. And literally this Sunday is our 23rd anniversary of serving the brain tumor community. Almost 23 years ago, my husband and I said, you know what? Let's change this. Let's change patient access. Why do patients have to wait until they have a recurrence before they get to, this is back then, guys, remember this, right? A lot has changed, which is so exciting. But why do we have to wait for recurrence before we can think about entering into a clinical trial? And why is much of the burden for patient access placed on the patient or the caregiver or their family member? So we said, you know what, let's create a foundation that addresses this problem, and let's create increased patient access for these patients in this population, brain tumors, brain cancer, as well as metastasized cancer to the brain. So that's what we did. So I just wanted to acknowledge that and say it's been an amazing 23 years. Can't believe it's been that long, to be honest. We've seen a lot of progress, but I just want to say it's deeply personal for me, this disease, and I couldn't be more proud of the work the Chris Elliott Fund, which you now know as the End Brain Cancer Initiative, has done in the last 23 years. And so we're super excited with our advocacy work and pushing the envelope forward related to research and patient access. So thank you so much for giving us that opportunity, and happy 23rd anniversary to the End Brain Cancer Initiative. I wanted to let you know that this program is being presented live via social media, via Facebook, and we're proud to be able to put this program out there via that method as well. We also can't do this kind of programming without the help of our individual donors and our corporate sponsors. And I want to say a deep, deep, deep thank you to both Telix and Novocure for coming in as presenting sponsors for this program. Novocure, you know, was the very first device company that had a device that was FDA approved for glioblastoma. So think about that, you know. Thank you, Novocure, for taking the chance and investing incredible amounts of money and resources into this. And now you know Novocure, you know the Optune device to treat GBM. And now Novocure has also entered into other cancer disease states and have approvals in other areas as well. So thank you, Novocure. And Telix is a fairly new company in the GBM space, to my knowledge. And they are working on an imaging agent to increase diagnosis as well as treatment. And so we're super excited to hear more about that today. So thank you, Telix, for helping to sponsor us as well. We also have in-kind and financial sponsorship from Great Purpose Productions, Integra Foundation, WIM Social, UCSF, Oxshire Health, which is in New Orleans, Louisiana, and the Preston Robert Tisch Brain Tumor Center with Duke. So thank you so much. And also within this program today, we will be presenting our National Hope Award. So this is a program that is a patient disease education awareness outreach program. And every May, we look at nominations that come into us, and people are nominating patients with GBM that inspire them. And so we've met with many of them, we've learned their story, and we too have been inspired. So we have 2 runner-ups and we have a winning recipient that we will bring forth to you today. And I want to thank Novacure has been a very, very long supporter of this program. And once again, this year they're supporting this program as well. So thank you so much. This is the team behind all of the work that the End Brain Cancer Initiative does to serve its mission, all of our programs and our services. So we're a small group of mighty, mighty, mighty people. And I just want to say a deep gratitude to each and every single one of you. There's several of you who are working behind me, behind the scenes, to bring forth this program today. So my deep gratitude to each of you. Thank you. Oh, again, it's an honor to be celebrating our 23 years of serving the brain tumor and brain cancer communities. So thank you, and thank you to each of you for all of your support. I think we need to start our program. Are you guys ready? Oh, of course, we can't do what we do without support. So those are different ways that you can actually support the work of the End Brain Cancer Initiative. So you can either text EBCI to 44321. You can, of course, go to our website all the time. And of course, you can scan the QR code on your screen to provide support. So thank you. So without further ado, I would love to introduce Dr. John Groot to you. He will be our first speaker today. And let me share a little bit about him with you. He is a professor of neurology and neurosurgery and neuro-oncology, division chief in the Department of Neurosurgery at UCSF. His broad clinical and laboratory experiences enables effective translation of novel therapies into the clinic for the treatment of patients with primary brain tumors. He has significantly contributed to the clinical development of angiogenetic, I should know that word, molecularly targeted and immunotherapy treatments for GBM, and he regularly advises companies on such agents in development. He has been the PI, the principal investigator, for over 40 clinical trials, and he's a collaborator on over 80 other studies. Thank you, Dr. Groot. That's amazing. Preclinical collaborations with multiple pharmaceutical companies assisted with the development of drugs for glioblastoma patients, resulting in investigator-initiated clinical trials and influenced larger company-sponsored trials. Thank you. His clinical research efforts are focused on identifying mechanisms of resistance to targeted and immunotherapies. He is developing next-generation trials using novel drug combinations and interventional techniques, including blood-brain disruption using laser ablation and focused ultrasound. I introduce you to Dr. John Groot. Thank you, John.
Well, thank you, Delanne. Thank you so much, and also to the End Brain Cancer team for inviting myself and Dr. Villanueva-Meyer to present today. It's an honor to be here. I remember, I'm old enough to remember hearing about Chris Elliott back when I was a fellow at MD Anderson, and it's really incredible what you've done over the last 23 years. So congratulations to you and your team. So I'm going to present some updates. Oh, sorry, disclaimer first. So this is non-promotional educational content, and just to let you know that we will not be talking about any agents other than those that are currently under investigational use. These are my conflicts of interest. As mentioned, I do some consulting with various pharmaceutical companies. Okay, so today I'm going to start off with going over an overview and some of the epidemiology, which you're probably all aware of. Talk a little bit about the new WHO grading criteria, some standard of care updates, and then talk a little bit about sort of trying to stoke an immune response in glioblastoma to help improve outcomes. And then I'll hand it over to Dr. Villanueva-Meyer, who's going to talk a little bit more about some of the imaging challenges. And then we'll finish up with a case review to discuss sort of the utilization of this new PET agent to help us guide management and treatment of patients. So everybody's probably well aware of the incidence of primary brain tumors. These are not very common, maybe 12 to 15,000 newly diagnosed glioblastoma every year, compared to 250,000 breast cancer diagnoses every year, for example. But what is very challenging is that this disease hits sort of patients in the prime of their life. And so there's a huge amount of loss of potential life years for these patients diagnosed so early. The clinical presentation, I think this is sort of pretty basic information. Thank you. Obviously, the presenting symptoms are related to where the tumor is actually located and also the rate at which it's growing. There also can be increased edema and intracranial pressure, all of which can lead to things like seizures, focal neurologic symptoms, headache, dizziness, or speech difficulty or weakness, again, depending on the location. So most patients will end up going to an emergency room or to their primary care doctor, who will order a CAT scan usually first, and then this is usually followed with an MRI scan. And as you can see here, these are some of the very typical, but also very rapidly evolving lesions that can result in what we call a ring enhancing lesion, which we'll talk about more later. So glioblastoma is the imaging sometimes is really almost pathognomonic. It really looks like a glioblastoma the first time you see it, and it has to do with that rim of enhancement. It has to do with the surrounding edema, and then sort of this diffuse infiltration throughout the brain. In terms of the next steps, then patients would go either to a biopsy or a surgery. These types of tumors are graded and not staged. You might have heard breast cancer, stage 3A. We don't use staging, we just use grading. Glioblastoma is by definition both IDH wild type and grade 4. There are other lower grade tumors, and we now know these tumors are IDH mutant, and we'll talk a little bit about that. But astrocytomas can be World Health Organization grade 2, 3, or 4, whereas oligodendroglioma are IDH mutant. They are 1p19q co-deleted, but they are only grade 2 or 3. And this is sort of a summary of what I just mentioned. The diagnosis and the pathology reports now are what we call an integrated diagnosis, which was first introduced in 2016 and then sort of further elaborated on in 2021. And this integrated diagnosis includes both the histopathology, so what the pathologist sees under the microscope and the description of that, but also combined with the molecular data. And so it's really critical that any patient who has a brain tumor, that their tissue is actually sent for sequencing for the majority of these sort of important genes that are shown here in the table, IDH1 and IDH2, 1p19q. And then there are a couple of other important ones, such as CDKN2 and A, CDKN2A and B, homozygous loss, which is a poor prognostic sign, and then the other one being MGMT, methylation status. If you look at the distribution of primary malignant brain tumors, as you see on the bar graph, the pie chart on the right, you see glioblastoma taking up about half of all cases, and then a smaller proportion of anaplastic astrocytoma, which we now call astrocytoma IDH mutant WHO grade 3, and then oligodendrogliomas, an even sort of smaller piece of the pie. Median age of diagnosis for the lower grade tumors is around 40, compared to median age of diagnosis for glioblastoma, which is around 65. For all of these tumor types, they are more common in men than in women. The impact of the World Health Organization classification on overall survival is shown in this slide here. The median survival for glioblastoma, we typically put at around 16 months. IDH mutant astrocytoma grade 4 has a better prognosis, but in between glioblastoma and the lower grade IDH mutant tumors, the top kind of two bars there are the oligodendroglioma, World Health Organization grades 2 and 3, and then the two dotted lines below that are astrocytoma and oligodendroglioma grade 3. So there are, I think, this is a pretty short overall survival curve. It only goes out to 24 months or 2 years, but really to sort of highlight this huge distinction in survival between glioblastoma and grade 4 astrocytoma versus the lower grades. The care for patients with diffuse glioma is really a multidisciplinary team of people who all come together around providing really integrated and comprehensive care for patients with these very complicated tumor types, but also an array of complicated and difficult to manage clinical situations. So not only is the neuro-oncologist heavily involved, but neuroradiologists like Dr. Villanueva-Meyer, pathologists, neurosurgeons, psychologists, and also I think it's really critical to point out the important role of social workers, patient support groups, and also caregiver support groups, sort of to take care of the patient and the family. If you look at the known prognostic determinants for outcome, they are age, younger age, obviously performing better. The Karnofsky Performance Score, which if you're not familiar with that, I have just a really brief slide on that in the next slide. Females live longer than men do. The extent of resection, with the greater extent of resection, is correlated with better outcome. There's mixed information on clinical trial participation. Some studies suggest that patients do better. Actually, other studies suggest that patients actually do worse. And then, as we mentioned, MGMT promoter methylation status is really critical, with those being methylated, doing much better and responding much better to treatment. And CDKN2A homozygous deletion, which is associated with a worse outcome, particularly in the IDH mutant tumor types. I just wanted to put this up in case people were not familiar with the KPS scale, and just sort of extending from 100, basically being, fully functional, all the way down to, a KPS of 6 to 60, where assistance might be needed, but is able to care for most of their needs, and then sort of decrements below that as shown. So where are we today in 2025 in terms of what we know is effective for the treatment of adult glioblastoma? Maximal safe resection, conventionally fractionated limited field radiotherapy with concurrent daily temozolomide, and then 6 to 12 cycles of adjuvant temozolomide. And then tumor treating fields were approved in 2011 for recurrent disease and 2015 for newly diagnosed disease. There are a couple of more recent updates, which I think have not really changed the standard of care, but there are for some patients. So we know that hypofractionated radiotherapy, so that means sort of a shortened course of radiotherapy. Instead of doing the traditional 6 weeks, it's a 3-week course of radiation. Improves survival in elderly patients. We have looked at dose intensification of Temodar, so basically tripling the dose of Temodar given. This is not associated with improved outcomes, so more is not always beyond 6 cycles of adjuvant was also not associated with improved outcome. There is no difference in recurrent glioblastoma survival for patients who underwent reirradiation alone or reirradiation with bevacizumab or Avastin. And then we also, which I'll talk about in a minute, we know there has not been any improvement in outcome with the use of checkpoint inhibitors, these immune checkpoint inhibitors that are approved for many different solid tumors, including melanoma, lung cancer, breast cancer, and various other diseases. So you'll hear quite a bit from Dr. Villanueva-Meyer about some of the treatment challenges that we had, but given that we just sort of discussed radiation and concurrent temozolomide, I wanted to sort of talk about pseudoprogression. I think people all know about this potential phenomenon. Here is an example of a patient who developed radiographic changes 4 weeks after completing radiotherapy, where the contrast enhancing lesion is, twice as big as it was before radiation. But and then at 8 weeks after radiation, this lesion continues to be large, but then 6 months later decreases quite dramatically on its own. And this is all without a change in treatment. So there was just adjuvant Temodar given in this patient. There was no other use of any therapy. And this really is something that requires a lot of patience in terms of trying to wait for responses to occur. But also, this is a real challenge. We see this in probably 30 to 40% of our patients, and it's difficult to be in the clinic with a patient showing a lesion that's larger than it was despite aggressive treatment. And so I think Dr. Villanueva-Meyer will kind of speak to some of the new imaging technology that might help us differentiate and help bring some better clarity in terms of what we're dealing with in these situations. In recurrent glioblastoma, there's actually no standard of care. Re-resection, we do frequently, probably 20 to 30% of patients will have a second surgery. And this is usually for patients who have good performance and where access to the lesion is easy. Reirradiation is also commonly done, but has been very difficult to demonstrate an improvement in outcome in randomized trial, in part, I think, because we're really selecting the best patients when we enroll patients for reirradiation. There are various other chemotherapy options as listed here. And then we always, first and foremost, try to identify clinical trials for patients. This is many times limited to first or second recurrence, and prior Avastin exposure is often an exclusion. So just wanted to look at a couple of the recent updates to the field. So, we mentioned molecular testing sort of across all academic centers now, and also with some commercial payers. There are opportunities to do next generation sequencing, looking at genetic alterations across the tumor. And basically, glioblastoma looks very much like other tumor types where you see very specific mutations in targetable lesions in patients with glioma, much like you see in patients with other solid tumors. However, there have been very few drugs that are targeted therapies that have actually sort of met the benchmark for improving outcome for patients. There was a recent study just published a couple of years ago looking at patients with BRAF mutations, both low and high grade tumors, and treated with dabrafenib and trametinib, which is a BRAF and a MEK inhibitor. And as you can see in this table below, there was a really nice number of patients who had response rates, objective response rates for grade 3 tumors, where 40% of patients, and in glioblastoma, 32% of patients had a response rate. And this is very high compared to what you might see with a chemotherapy like lomustine, where you might see 5% of patients actually responding to the therapy. So this is really exciting, and I think this is a really important advance. And this is a patient of mine who had a tumor very deep in the brain, not accessible by surgery. As you can see here, this was a BRAF mutated tumor. And you can see just a couple of months after starting on treatment with the BRAF MEK inhibitor, you can see a really dramatic and nice response to that treatment. There's been a lot of interest, and you heard from my bio that I've had a long-standing interest in anti-angiogenic therapies. We always thought this would induce blood vessel normalization and allow better drug delivery and improve the efficacy of radiation, as well as potentially alter the tumor immune microenvironment to make this a more treatable tumor. But what we have found is that this can induce really quite dramatic imaging changes. As you see here on the top row, this is before bevacizumab, and then below it, just within 1 month, you can see a dramatic reduction in contrast enhancement. So much like you see pseudo progression, this is almost like a pseudo response, right? So this is really just due to the drug blocking permeability of the blood vessels and preventing the leakage of contrast enhancement. And we have looked at this drug to see if it improves overall survival, which we, in 2 randomized studies, unfortunately did not improve survival for patients who were randomized to receive standard of care with bevacizumab versus just standard of care alone. So there's a lot of different immunotherapies. I think myself included are really excited about some of the opportunities in immunotherapy. There are some vaccine studies that are ongoing, multiple oncolytic virus studies that are ongoing. But most of the work that we've done has been with immune checkpoint inhibitors, and then sort of a developing field in the CAR T space. So this is the phase 2 study of the Survaxim trial, demonstrating, as you can see in the bottom right-hand curve here, improvement in outcome in patients who had a systemic IgG response to the vaccination. This agent is currently in a randomized phase 2 trial that I think is close to or has already completed accrual, and we're now just waiting to see what the outcomes are between the two groups. The most mature data, though, that we have comes from immune checkpoint inhibitors. These are the ones, as you can see on the right, that have been approved in so many different solid tumor types. But as you can see, nothing listed in the brain here yet. There was a clinical trial comparing nivolumab, which is an immune checkpoint inhibitor, versus bevacizumab in patients with recurrent glioblastoma, which unfortunately did not improve the median survival for patients. And then there were two randomized phase 3 trials in newly diagnosed patients, one group with unmethylated MGMT, where nivolumab was substituted for temozolomide, and then also a separate trial in methylated MGMT methylated patients, where the nivolumab was added to standard of care of radiation and temozolomide, as well as adjuvant temozolomide. And unfortunately, both of these trials were negative in both the unmethylated and methylated groups. There was no improvement in overall survival. There's been a lot of excitement around the use of CAR T cells, and this is just demonstrating a couple of studies. These two are from Penn University. Steve Bagley is the first author in both of these studies. The first one looking at infusing CAR T cells into the bloodstream, so intravenously, and they felt like there was no efficacy in a small number in 8 patients with recurrent glioblastoma. However, they used a different CAR T cell that was targeting both EGFR and interleukin-13 receptor, where the CAR T cells were given intrathecally, so into the cerebrospinal fluid space, and they were able to show proliferation of these cells in the cerebrospinal fluid. But unfortunately, we're still waiting to find out if they actually made it into the brain tumor. And then Michelle Manji at Stanford has also been using CAR T cells for some diffuse midline gliomas. Sorry, this slide is a little blurry, but showing radiographic responses as well as improvement in symptoms. And lastly, a group in Boston just recently published this study where they have a very unique CAR T cell that actually secreted a molecule that could actually target factors within the tumor microenvironment. And they were able to demonstrate an improvement in, or a reduction in, contrast enhancement in patients, even within 1 day of treatment. But unfortunately, not shown here on the right is that these tumors did recur relatively quickly. And so I think one thing to note, again, as we emphasize the importance of novel imaging modalities, the checkpoint inhibitors and other immune therapies can really induce some significant imaging alterations. This is an example of a patient treated with pembrolizumab, which is an immune checkpoint inhibitor. And you can see the time course of changes where before treatment, 4 days after treatment, a dramatic increase in contrast enhancement. And then even within 1 week, quite significant increase in the size of the lesion as well as surrounding edema. And it's very difficult to know whether this is actual tumor growth or whether this is pseudo progression. And I think, this is just a brief slide to just suggest that, imaging as a surrogate, it can be challenging with any immunotherapy, and hard to know whether what we're viewing in such a short amount of time is related to the therapy or the immune response to the therapy. So just to summarize briefly before handing off, targeted therapy is challenging. There are very small subgroups of patients who, however, might benefit. We know that, there are probably subsets of patients that are responsive to immunotherapies, and identifying biomarkers for who might respond to such therapy is really important. And then it's really an important feature for us to better understand how to improve delivery and the biodistribution of treatments to brain tumors to help improve their efficacy.
Thank you so much, Dr. Groot. Thank you so much. Let me introduce you, if I may, Dr. Villanueva-Meyer. I meant to do that earlier, and I apologize.
No problem. Thank you.
He is an associate professor in the neuroradiology section in the Department of Radiology and Biomedical Imaging at the University of California, San Francisco. He received his medical degree from Baylor College of Medicine in Houston, Texas, and he completed his 1-year internship at Virginia Tech, Carillon School of Medicine in Roanoke. He completed his 4-year diagnostic radiology residency at UCSF, followed by a neuroradiology fellowship also at UCSF. He also completed an NIH, so National Institute of Health, T32 postdoctoral fellowship in the UCSF Department of Radiology and Biomedical Imaging. His interests focus on advanced MR imaging and imaging-based tools to better delineate and characterize brain tumors. Thank you. His research also involves molecular imaging, where he works with collaborators within and outside of his department to develop and implement the use of PET radiotracers in both brain tumors and spinal infection. He has experience in CT, MRI, and plain film radiography of the brain, head and neck, spine, and peripheral nervous system in both the inpatient and outpatient settings. And there's lots more, but we'd love to hear from you directly. Thank you.
Thank you so much for that introduction. I really appreciate it, and thank you for the invitation to join this group. As a neuroradiologist, we are not directly patient-facing. I do a fair amount of procedures in my practice. However, that's mostly geared toward pain interventions. So on the oncology side, always appreciate any opportunity I can to meet and interact directly with patients. So again, thank you for that. And I think that's a great segue into the critical role of imaging in neuro-oncology. Every visit is essentially punctuated by imaging, organ, in that we don't have easy way to understand the status of disease within it when it comes to brain cancer. We can't just, sample the tissue. We don't have great blood-based or even cerebrospinal fluid-based biomarkers. There's a lot of work in that space right now, and the hope is that in the near future that will be the case. But for current state, imaging, neuroimaging is really the primary way by which diagnosis and treatment response is done. Unfortunately, our current imaging techniques, the standard of care we have, aren't as sensitive or specific as we would like. The bread and butter types of imaging that we perform, T2 FLAIR and T1 post-contrast MRI, this is anatomic MRI, can represent tumor or not tumor, as highlighted in these example images, where we have tumor, edema, and gliosis or scarring, all showing up as bright signal on this T2 FLAIR. And then post-contrast enhancement, which you can see on this bottom row here, can indicate either progressive tumor or treatment effect. And so every day when we're out in clinical practice, we're in some cases it may be pretty clear cut, but in many cases we're kind of left scratching our heads. And so we have a number of additional tools that are at our disposal that we've developed to try and help us sort this out. And I'll call them out here. Where most imaging centers will include what we historically have called and still call advanced imaging, so diffusion weighted imaging and perfusion weighted imaging that speak to cellularity of tissues as well as blood supply within those tissues. And in some cases, we may bring patients back for MR spectroscopy, which allows us to understand what's going on in terms of the metabolic activity of tissue. We use this for troubleshooting technique. We mentioned earlier positron emission tomography or PET imaging. This is another great troubleshooting tool that we're looking to integrate more and more into routine clinical practice, and it'll be the focus of what we're talking about here. And then there's some other bleeding edge technologies that are really sort of coming out of the research realm and into the clinical realm. One of those is hyperpolarized carbon imaging. That also allows metabolic imaging, but in a little bit more of a dynamic fashion. More often than not, as I mentioned, we're unfortunately left just getting repeat imaging for our patients. So we see something that's indeterminate. We try to use these tools to the extent that we can, but more often than not, we end up having to have the patients come back. I'll call out that sometimes, unfortunately, when that happens, the cat is already out of the bag. So here in this bottom right example, we saw a little area of bright signal on this T2 FLAIR where I'm hovering my mouse. It's very small, very subtle. We didn't really know what to do with it. We said, come back. And unfortunately, by the time the patient came back, this lesion had already grown and there was an additional lesion as well. And so that's the emphasis of, or the aim of many of these metabolic imaging tools, is to try to understand what's going on underneath the surface and try and catch disease before it limits, you end up with limited treatment options, right? So that's the end goal here. And I'll also call out the fact that there really is no singular silver bullet when it comes to imaging. Each of these tools, or each of these different techniques, represents an opportunity to reduce our uncertainty as clinicians. And so, we stack all of these things together. There's not one single one of these tools where it's like, okay, based on this technique, it's 100% this is what we're dealing with. It's really, we're playing a game of odds, and each of these things help us to varying degrees, and unfortunately, varying degrees in every case, in every patient. They're all very, very different. So because of that lack of sensitivity and specificity, as I've kind of already been alluding to, we're left with a host of unmet clinical needs. We have definitely a need to better monitor treatment response to conventional therapies as well as to trial therapies. And in the trial setting, we really want to know what's going on as soon as possible so we can make distinctions or any changes to these novel trials that Dr. Groot mentioned earlier. We also have a need to predict malignant transformation, again, helping us understand what's going on beneath the surface, beneath the anatomic imaging. If we had a way to understand, okay, this tumor is going to be more aggressive, that would be incredibly helpful. Identification of additional sites of disease, and then also helping us understand the relevance of this non-specific T2 hyperintensity that I mentioned earlier. And lastly, diagnosis and prognosis. In many of our brain tumor cases, the first line of therapy is removing the tumor. So for that reason, I kind of put this last, is that these patients will often, many patients will often have to have surgery first for diagnosis anyway. So while it's great that we can try to give the best guess right up front, if we, if we can't clearly define exactly what kind of molecular markers the patient has, that'll be fine because the patient will undergo surgery and we'll have that answer then. So Dr. Groot showed you earlier an example of the classic problem that we face in neuro-oncology, which is that of treatment effect versus progressive disease related to the lack of specificity of our standard of care imaging. I'll show you another example here. These are two patients who both underwent gross total resection of high-grade glioma, and what that's defined as is resection of the enhancing or contrast-enhancing part of the tumor. In these two examples, we see no residual contrast enhancement. This top one, you can argue that there's some bright signal around this. I'll tell you that that all represents blood products, and it's not true contrast enhancement. These patients both underwent chemoradiotherapy, so the standard of care treatment with temozolomide and radiation therapy. Following completion of that chemoradiotherapy, they had growth of contrast enhancement around the surgical cavities, as you can see on both of these images. The patient on the top continued to have growth of that contrast enhancement. Now it looks bulky and nodular, whereas the patient on the bottom, that enhancement started to fade away. So the top patient represents progressive disease, whereas this bottom case represents pseudo-progression or treatment-related changes. So what we would like to know as treating clinicians is, based on this middle exam, which one of these represents growing tumor versus which one represents treatment effect, so that we can make appropriate changes in our management and not have to wait that 4 to 8 to even 12 weeks in some of these cases to make a treatment change. So to help address that ambiguity, I mentioned earlier positron emission tomography, or PET. This is a nuclear medicine study that relies on injecting a radiotracer. So it's a small radioactive agent that's injected intravenously and taken up by tissues, and helps us understand what's going on from a metabolic perspective. The classic PET imaging agent that you maybe have heard about is called FDG, or fluorodeoxyglucose. Essentially, the premise behind the use of this agent is that cancer cells are metabolically active or hungry, and so they take up glucose to continue to grow. And they do that at a greater rate than normal tissues around the cancer. And so the challenge that we have with using FDG, which is the most commonly used, or fluorodeoxyglucose, the most commonly used radiotracer in oncology, the challenge we have in the brain is that the brain normally takes up glucose. And so you have a lot of background uptake of this radiotracer, and it can obscure subtle findings within the lesion. And so as a result, using that same premise that these cells are more metabolically active, so they're requiring these building blocks, amino acid PET agents have been introduced now routine clinical use. So these have come out of the research realm and are really in clinical use in Europe. And we're working hard here in the United States to get FDA clearance for these agents. And that's part of the work that we're doing with Helix in collaboration. So these amino acid PET agents, there's a number of them. I highlight three of the most common ones here: FET or fluoroethyltyrosine, F-DOPA, which is also used for Parkinsonism, and MET or methionine. These all represent amino acids or building blocks of proteins. They're going to be taken up by cells that are more rapidly dividing, that are growing, and therefore, more likely to be synonymous with cancer versus something that's inflammation, where you don't expect to see that high level of uptake. There's a couple of other agents, such as FACBC, that I call out here. There are some other agents as well that have been studied in neuro-oncology, but those they're targeting different aspects of metabolism. So fluoroethyltyrosine has the benefit of having no further metabolism, so they're just basically taken up into cells and they're not broken down any further. So that's great for the type of imaging we're trying to do. They circulate in the body for around 2 hours, which is also good from a clinical perspective in terms of imaging. Some of these that are carbon-based radiotracers, as you can see here on the far right of the screen, have a very short half-life of about 20 minutes. So you really need to be able to image them pretty quickly. This again highlights the minimal uptake in the normal brain that I was describing, and underscores how much easier it is to see neoplastic or tumor tissue relative to the background activity in the brain. So that's why we like this agent. And so with that, I'm going to sort of tag team this now with Dr. Groot. We're going to talk about a couple of cases where we've used this radiotracer at UCSF as part of a trial to help us with some of the ambiguity that we saw on MRI. And so I'm going to hand it over to Tim to run us through this case, and I'll talk through the imaging findings.
Yeah, so the first case is really a question of, are we dealing with recurrent glioblastoma? 62-year-old male with GBM, MGMT methylation, and then went on in one of the immunotherapy trials that I mentioned before, where the patient was treated either with nivolumab or placebo for newly diagnosed glioblastoma. So that included radiation, concurrent and adjuvant Timidar with or without this immunotherapy, and while on treatment developed some imaging changes.
All right, and so those imaging changes that we're describing here are shown on screen right. This is an MRI. This is a post-contrast image, and you can see that there's some contrast enhancement along the left lateral ventricle. Remember, in imaging, the right and left are flipped. So we see some enhancement around the left lateral ventricle. There's also some swelling or some edema around it. Because of those changes, we got a short interval follow-up. So we had the patient come back at 4 weeks' time. And at 4 weeks' time, that enhancement continued to grow. You can see this lesion is bigger. But interestingly, there's a lot of necrosis associated with this lesion. This is a lesion that if I were reading, I would say, okay, it's growing, yes, but there's a lot of necrosis. So maybe I would favor it to be, while indeterminate, I would maybe favor it to be more treatment-related changes rather than progressive tumor. Patient went on to get fluoroethyltyrosine PET MRI. And here we can see that there is some uptake within that lesion, but you can see relative to the rest of the normal brain, it's not very, very high. And I don't have the color scale here, but I can tell you that this is not something that would be classified as visually positive. We can also get some quantitative measures from this. So we can look at what's known as a tumor to background ratio, and tumor to background ratio above 2.3 is considered positive. Here, this tumor to background ratio is 1.5. So this is what we would call a negative study. This patient underwent surgery, biopsy, and I'll just call out that this was found to be predominantly treatment-related changes, and viable tumor was found in less than 5% of the pathology. So
yeah, so this, the patient really went to surgery because they were on a clinical trial, and we really needed to know, was this actually, tumor progression, at which point we would have to take the patient off. But the FET-PET favored treatment effect, and that was confirmed at the time of biopsy. So the patient was able to continue on treatment following surgery.
And this is our second case here.
Yeah, so the second case is also a question, is this recurrent glioblastoma or not? This is a 46-year-old woman with an IDH mutant astrocytoma, WHO grade 4, MGMT methylated, underwent a subtotal resection, radiation with concurrent adjuvant Timidar, and then 7 years later, without any progression in between, had some imaging changes that were concerning for potentially radiation effect.
All right, so again, on screen right, we have the index MRI where we see a resection cavity in the right temporal region. And just along the back margin or the posterior margin of that, we see some areas of contrast enhancement. You see these little bright dots here. It looks kind of fluffy. And then this person undergoes a standard 8-week or 2-month imaging follow-up. At that time, it's pretty obvious this lesion has grown, but there's some mass effect associated with it, meaning it's kind of bulky, it's extending kind of into the cavity or pooching into the cavity there, even though there's some necrosis. So this is something that I would read as indeterminate, but favor growing tumor, favor progressive disease. This patient also underwent fluorethyltyrosine PET, and here, in contradistinction to the other case we saw, we see that there's a lot of red in this lesion, right? So this is something that is visually positive, so qualitatively positive. And then if you remember, I mentioned the tumor to background ratio. Numbers above 2.3 are considered positive. This is 3.4, so this is unequivocally positive tumor based on the fluorethyltyrosine PET. This person underwent surgical resection, and as noted here in bold on the pathology report, approximately 70% of the tissue is viable high-grade glial neoplasm.
Yeah, so despite, the imaging changes that were concerning, but maybe indeterminate, the FET-PET really actually drove the decision to take the patient to surgery, and pathology confirmed, recurrent disease. And of course, that's critical for planning the next stage of treatment for the patient.
Perfect, thank you. So some quick lessons learned from our early experience with amino acid PET at our institution. Number one, as I mentioned earlier, these tumors are incredibly complex. There's different molecular underpinnings to these tumors, and patients undergo a number of different therapies. There's not really a one-size-fits-all or silver bullet here. Metabolic imaging brings a wholly new dimension to our armamentarium to help patients. So when you see changes there, do go back and re-review the MRI. I think something that's critical is exactly what you're seeing here, where you see Dr. Groot and I speaking back and forth, this multidisciplinary approach where you have radiologists, pathologists, radiation oncologists, neuro-oncologists, and neurosurgeons, everybody working in concert to treat this disease and make sure the patients are being managed appropriately. All of those things are critically important. And so with that, I'm happy to take any questions. Really do appreciate, again, this opportunity.
Thank you so much, Dr. de Groot and Dr. Villanueva-Meyer. Wow, really impressive. I feel like I want to cut radiologists some slack. You know what I mean? When you're looking at those images, right? Because it's true. You don't exactly know what you're looking at. I have a question for you. So the FET-PET, right? Just if it moves forward, right, and it keeps continuing, the data keeps showing response, et cetera, and eventually this is FDA approved, it's a game changer for these patients and these caregivers and family members because of the terrifying times, before an MRI for the patient and their family. It's terrifying. It's horrible. Yeah. And thinking about this application, obviously this application would determine if it's, tumor growth, real tumor growth, or, treatment effect, or basically I say fake tumor. I just can't imagine the change in the landscape related to surgeries that this would then offer up. Has there been talk about that aspect of this particular treatment approach, diagnostic and treatment approach?
Yeah, absolutely. So I really appreciate you calling out that the emotion attached to basically coming up to the MRI, and then after the MRI waiting for the report, waiting for the results. totally heard, and that's something incredibly important for us to keep in mind as we're making these interpretations and what that means for you all as patients and caregivers. So that all of the examples I showed of fluoroethyltyrosine PET or FET PET were really single time point, right? It's really just help us troubleshoot at this one time point. The next chapters that are to be written with this agent are, how do we use this to better define treatment up front? Just like you said, like, surgery. Okay, we have this huge swath of MRI abnormality, but the areas that are metabolically active are here. So let's preferentially go after this. And then the other next chapter that I'm really excited about is really using this at multiple time points in the same way that we use MRI, right? So how is somebody responding, even though their MRI might not be changing, or maybe changing in a potentially, kind of questionable way? If we can show that there's metabolic change within the tumor, slowing the rate of growth or anything to that effect, that is also, one. So just speaking of, just to add on to your enthusiasm and excitement, that's what we're excited about in terms of where the field is going.
Fantastic. You answered some of the questions that came in, which were, what will the future for, radiotherapy in brain cancer be? So you just answered some of that there. Someone wrote in, they're a family member of a GBM patient, and they wrote in, would like to know more about Telix, how to get it, and if insurance covers it.
Right. Yeah, I mean, Telix has really been in the field of radiopharmaceuticals for quite some time across multiple indications, not just for brain tumors. As you mentioned, they're more recently new to the brain tumor space. They are working very hard to get FDA approval for the FET-PET. It has been approved in Europe for the last 20 years, and so they've been able to do it in Europe. I think if it gets approved, then there will be efforts to make sure that this is paid for by CMS and then by third-party payers. I think there's some questions about, how long that might take, and then, to what degree could we do some of the things that Dr. Villanueva-Meyer mentioned, like do this serially? Would they pay for it just once, or would they allow us to do it, every 8 weeks? So lots of uncertainty around that.
Right. And yes, the future will tell. As patient advocates and as a patient advocacy organization, Telix does know this, but we're in a position to help when it comes to the approval process. And of course, with Medicare and that work, we've done quite a bit of that in the past. And it's extremely important to bring this forward for approval. And yes, it takes a while, but it's advocacy. And also, it's not just advocacy organizations that can help make a difference. It's everybody that's tuning in today and more, because what we can do oftentimes from an advocacy perspective, we create the movement, we create the opportunity to hear from patients, caregivers, their family members, healthcare providers, about how important it is to have something like this diagnostic imaging opportunity approved. So I foresee that happening in the future. So this is a pre-invite to join us in that movement in order to increase patient access, as well as, in my opinion, increase survivorship, really, when you know what you're looking at as far as tumor tissue. So I have a question, and I asked this as a friend. Villanueva-Meyer, there was a slide, and your slides aren't numbered, but there was a slide you were talking about, and you had an image up there. It was an initial image, I think, and then maybe, I don't know, it might have been 8 weeks later. But the first image, it showed what you couldn't, the white enhancing, and you said we didn't really know what to do with this. Do you remember?
Yeah. Yeah.
Okay. So my curiosity is, what would have been a different approach? I'm just curious, and I'm asking this literally as a friend. I don't want to put you on the spot, but I think about, if I'm a patient, right? And there's something there,
Yeah.
I
Yeah.
want something done immediately,
Yeah.
right? So I'm just curious, what
Yeah, so I think you're referring to the first case where there was something that was growing, and I said we didn't really know what to do with this. And I remember actually having the phone conversation with my neuro-oncologist colleague. This was a patient of Dr. Oberheim Bush's at UCSF. And, it was just the imaging was obviously growing and convincingly growing. And the patient was somewhat symptomatic from the edema, right? And so from the swelling. And so there was a question of, just as you said, the patient wanted something done. And so despite, my reassurance, and this was actually, I believe this was one of the first 5 patients we did with fluorethyl tyrosine. So there's a little bit of a learning curve that was associated with this. So there was like, well, it's telling us it's negative, but there was this pressure, like you said, from the patient. I want something done. We have to know what this is. I'm tired of dealing with this uncertainty. So let's biopsy it. And so they did. And that's when it came back that this was all necrosis. And so since then, that helped build our confidence in that imaging tool to now say, convincingly, let's call it, have that discussion with patients and say, look, this is telling us it's negative. We're convinced, we feel strongly this is negative. And so, we're gonna stay the course, or we're gonna manage you with steroids or anti-angiogenic therapy, what have you. But I think it's a good call out, because that same feeling was felt by the patient at that time. And that was early enough in our experience with this agent that I wouldn't say it's not that we had full trust in it, but there was a little bit of that uncertainty.
Yeah, and the point is too, like with FET, you literally could introduce it early and with confidence,
Yep.
show the patient, and that that patient is just going to have a huge sigh of relief.
Yeah. And
You
and
know,
for that, we're thankful for our patients who enrolled in this clinical trial. That was the largest prospective clinical trial that's been done to date with this agent. And that patient's uncertainty gave us the certainty to now move this forward, right? So it's amazing how the field progresses.
wow, that's great. I mean, you know, I'm speaking for all of you, but I know everyone listening today is just really excited about this. Well, I have there's a couple of questions that came in, and also please remember, you guys, we've got a couple of minutes. Someone says, with the FET PET imaging, do you believe there will be a nutritional metabolic, I think it's effect. Let me read that.
Yeah, I see that. That's an interesting question, and one that certainly should be explored. So we do ask for fasting, for example, with this beforehand, because we know that the degree of and in some cases, like even a low protein diet prior to this, because it helps facilitate how much uptake there is into the lesion. Now, that's not necessarily what this question is asking, but I share that just to say that there is some link there that needs to be studied further.
I also would like to see a nutritionist as part of the integrative team everywhere for multiple reasons. Can you see Dr. de Groot? Did you see? I want to congratulate Dr. de Groot on his move to UCSF. He helped me when I was first diagnosed with GBM back in February 2020 and overwhelmed where I should go for my care. Wanted him to know that I'm still here living with GBM over 5 years.
That's amazing. And thank you for the congratulations. I'm super happy where I am, although I miss a lot of my friends at MD Anderson, but I'm glad you're doing so well. That's really amazing.
That's very cool. I love it. I love it. This is a question that I wanted to open it up to whoever wants to answer it, doctors. It came from California, and they indicate they're a caregiver. Their question makes me wonder. We have a number of patients trying to decide on neurosurgery and having a challenging time deciding due to a tumor or cyst location that could cause harm or damage after effects. Any words of professional wisdom?
That's a tough one. I think, obviously you have to feel very comfortable with the surgeon and your care team. I think it's always a good idea to get a second opinion when you're dealing with, a major medical challenge. And so I think that would be just my only other suggestion would be to seek a second opinion.
Oh, yes, yes. Well, and as a patient advocacy organization, we always suggest and help patients receive that second opinion for sure. This is the last question, unless someone listening has a question they want to put into the chat box. And this is to whichever doctor would like to answer this. How PETs can be used for brain cancer and other monitoring options that don't use contrast?
That's a good question. So you don't need contrast to do additional contrast to do this. It is helpful. It is helpful to have the comparison side by side. And many institutions now have what we have, which is a hybrid PET MRI scanner. So the PET imaging happens at the same time as the MRI. Do you absolutely need contrast? The answer to that is no, but it is helpful. Do I see a world where maybe we move away from intravenous contrast and just use the PET potentially, but not I don't have super clarity on that. So yeah.
Yes, thank you. Thank you. A quick question came in actually from our patient navigator. Do you offer telehealth appointments for out-of-state patients?
Yes, we do.
Fantastic.
Yeah.
Fabulous.
Simple.
Thank you for doing that. It's a game changer.
Yeah, it's critical, I think, to get access, and particularly for patients who don't have necessarily access to specialized care where they live.
Yes, absolutely. So that is all the time we have for you, gentlemen. I want to thank both of you, not just for today and presenting, and everyone's going like this, yay, but truly for your commitment to this disease and this patient community and the research community. Someone just put up a nice heart. That was cute. Anyway, thank you so much. I want to introduce you to Torey Gilbertson today, and he is a GBM patient. He's got some really interesting words of wisdom through his experience. He was born and raised in Wyoming. He received his Doctor of Physical Therapy degree from Pacific University in Oregon in 2003. Throughout his career, Torey has worked with children of all ages as a physical therapist in Issaquah, Washington, both in a clinic setting and across 3 different school districts in the area, accumulating over 10 years of experience. He further advanced his education by earning a PhD in rehabilitation services from the University of Washington in 2015. In late 2015, Torey married the love of his life, and they purchased a home in Snohomish County in 2016. Since 2015, Torey has served as an assistant teaching professor in the Department of Rehab Medicine, Division of Physical Therapy at the University of Washington. In July of 2020, Torey was himself diagnosed with GBM after he experienced persistent yawning, increasing daily headaches, nausea, vomiting, and cognitive slowdown noticed by his wife. He began wearing the Optune Gio device in January of 2021. Torey, you have the floor, my friend. Thank you so much for joining us.
Perfect. Well, thank you so much, Delanne, and thank you to the In Brain Cancer Initiative for inviting me. Of the tens of thousands of Optune Gio users out there that you could have picked to talk about their experience with Optune Gio, I'm very humbled that I am the one who was selected for this. You already went over a lot of my journey with brain cancer in that bio, so I will just skip to the juiciest parts, and that diagnosed July of 2020 in the height of COVID. And just prior to that, my life, I don't think could have been more perfect than what it was. The job was perfect. My wife was ideal, loved the house. I built some huge garden beds that we were growing vegetables and some berries in. Things were wonderful. And until the time I went to the hospital to find out that I had a mass. My surgery left me with very limited use of the left side of my body, so I had to work very hard in inpatient rehab to gain that back. That second picture in is the thumbs up with my left hand, because it was actually very exciting that I could move my left hand and get my thumb up like that. And then I learned my diagnosis of glioblastoma a week or two after my surgery, and it was the diagnosis that I feared the most. So there was a lot of feelings that came up with that. But my wife was by my side literally at least 20 hours a day throughout the rehab process, 24 hours a day as long as they let her stay. And then when they finally started kicking her out at night, a week or so after my surgery, she came back first thing in the morning and was with me for every step of the rehab process. So getting right into the crux of it, I have been wearing Optune Gio since January of 2021. And for those of you that are considering using it or new users, I highly recommend going to the NovoCure website and requesting a buddy call, or the Optune Gio website, so you can talk to an experienced user about their experiences as well. I have had the privilege of having many of those phone calls myself. So I know that I've got a time limit, so need to keep to it, but I've got so many tips to talk about. But one of the things that I really make sure that I try to do is work out to get a good sweat on array change days. It makes getting these arrays off so much easier. I had a monthly reminder set just so that my device support specialist didn't always have to reach out and remind me to upload my data, so she could look at my usage and my alarms and some battery issues and everything else. But now with the my NovoCure app, it sends a monthly reminder to upload your data. So that takes a lot of the self reminders out of it. It's really nice that it's automated. I also love that app to be able to track my own usage. You can use it to troubleshoot alarms if you're not fluent in Morse code, and because there's different beep patterns that mean different things. If there's an error with the machine, fortunately, those are fewer and further between for me at this point, other than the battery is low. But that the app has those same alarms that you can listen to compare with what your machine is doing with sounds on the app. Plus, you can order supplies right there on the app as well. And NovoCure has been wonderful with sending supplies as needed. Some of the other things that I've told people is just taking breaks as needed. I know it's recommended to wear it 3 to 4 days at a time before you take a break, but if you're a sweaty human like I am, I change 3 times a week now. But in the summer, when it's hotter and I'm doing more outside, I up that changing as needed. I'm not afraid to sweat at this point, and know that I can just change my arrays if it's important, because I also value my skin health and acknowledge that it's way more important to change arrays more frequently or take longer breaks to allow your skin to heal than it is to make sure you've got the highest usage percentage possible. I know a lot of people strive for upper 90s in usage, and now I'm happy if I get the minimum 75%, because I've been taking a little bit more breaks and really taking care of my skin. I did have a spot develop recently, and I had to be off of Optune for about 3 or 4 days. And that was the one time my usage dipped below 75%. And had I been a little more diligent going into it, maybe I could have avoided that, but it's one of those things that happens. I also like to use a little piece of foam shelf liner in the various places that I tend to keep my Optune Gio device. This helps to just mark it as kind of my spot to not clutter up with other things. And it also functions really functionally, where when I set the machine on and then maybe forget to pick it up when I walk away just a little bit, that it gives a lot more friction, so I get more of a gentle head tug than just pulling the machine off the surface that it was on. I've already talked about array changing as much as you want, but using the app or calling my NovoCure to get whatever supplies you might need is really, really handy. I have an extra battery and I got an extra few of the wall units, so I can just plug in and not use battery power at places where I'm at home and spend a lot of time, such as the living room, my home office, and by my bedside, so I don't have to worry about changing batteries during the middle of the night. And even if the supply that you want might not be available to order on the app, you can always call my NovoCure to ask for other supplies that you know they might have. And they're always happy to provide those for you as well. So when it comes to actually changing the arrays, I already talked about working up a good sweat. My favorite activity is getting on the exercise bike or doing some yard work or housework or whatever. But I really like to get that sweat. It makes it so much easier to get those arrays off when it comes time. And then when I shower, I like to use an anti-dandruff shampoo. For me, it's Dove Dermacare, just to because it has a lot of extra moisturizing in it. Then when I get out of the shower, I dampen my head with warm water. I use a very thin layer of shave gel for sensitive skin. And then I use the electric pit bull razor that my NovoCure provides. I do kind of 2 passes. One with clockwise circles, and then I rinse it off, and then one with counterclockwise circles on one side of my head and rinse it off. Then I repeat for the other side and the back. So I always shake that razor head off as much as I can so I'm not dripping a lot of water all over. But it works out pretty well. And then as soon as I'm done shaving, I like to rinse my head with cold water. And then I use the plastic packaging that the razor head came in as a little squeegee to scrape all the water back into the sink so I don't have a giant mess everywhere. And yeah, looking through to make sure I got everything. And then, yeah, drying my head with a clean towel every time. And I change the razor head about every 2 months. Anytime I feel like I'm not getting a close shave or getting any nick when I'm shaving is a good indication that it's time to change my razor head. Easy to order through the My NovoCure app or calling My NovoCure to get those new heads sent to you with an array or anything else. Then when it comes time to actually put my new arrays on after my 2 to 4 to 12-hour break, whatever it happens to be, I like to use witch hazel instead of alcohol because it's a little more moisturizing and still does a great job cleaning. And then I use a piece of cardboard to just fan my head to dry it off a little bit before spraying some skin prep on. And then use that same cardboard to fan to dry that. I have gotten to the point where I put my own arrays on now. Part of that was out of necessity. When my wife was away for a while, she changed my arrays for me for the first 3 years. But then she had a family medical emergency that she wanted to go be with them for a while and couldn't then change my arrays. So it was a great learning opportunity for me to learn how to change my own arrays. I'm able to do so now totally independently using just the one mirror in front to get the front and 2 side arrays placed well. And then I put the back one on more just by feel and the position of where my thumbs are in relation to my ears. And then occasionally I might grab another mirror to make sure I did an okay job on the back once it's placed. But and I've cut my arrays down quite a bit. Anything that's just adhesive and not wire or electrode can be cut away to make room for a little skin imperfection or something. And you can slide it around a little bit. You don't have to be exact with the placement each and every time. And so there's a little bit of wiggle room there so that you can kind of avoid angry spots for a while if need be. Want to make sure you don't ever cover an open sore with either the adhesive or the electrode part of the array.
Torey,
Yes.
you are inspiring all of us today. Your
Oh, I'm almost.
personality, besides the information that you're providing, is just wonderful. But your personality is, it's so warm, and you can tell you really like sharing this and your experience with others because you know it's going to help them. So I want to thank you for that. I do have Dr. Golden on standby who will be speaking next, but there's a couple of questions that I have for you, if I could ask you those.
Absolutely. I apologize for going so
Oh
long
no,
with that.
you're
I get
fine.
stuck into it. I get excited.
You know what? You're fine. You're fine. And the other thing is at later towards the end of this program, Torey has been really, really kind in putting all of this information into a fact sheet, which we will have, or it already probably exists now on our website. And so Shreya will tell everyone to find that in our patient resources. So your information will keep going and going and going out to help people as well. So question for you, this is from a patient from Michigan. What's the biggest challenge with Optune for you?
Getting used to it was the biggest challenge, figuring out where to store all the things and then just simply remembering to take it with me everywhere I went. I couldn't just get off the couch and start walking to the kitchen without remembering, oh, I got to take my machine with me. Otherwise, I get a pretty good head yank or pull the machine off of wherever it was. So just simply getting used to it and having it with me all the time.
Awesome.
And then remembering to take spare batteries if I'm leaving the house for a period of time.
Okay. And that's great advice. You've got one spare battery. Can you get like another, like two spare batteries if you wanted?
Oh, I have 5 batteries in total. They give you
Fantastic.
4 to start, and then I
Okay.
ask for 1 extra, and they last about 3 hours
Okay.
each. So
Oh,
you
that's
can get.
great. That's great. Really quickly, can you tell us about the wall units you were talking about?
Yes, it's just a small device that you can plug into the wall that then you can plug directly into the Optune device so that it stops using the battery power.
Okay.
As of yet, it does not charge the battery while it's plugged in, but at least it stops using the battery while it's plugged in. So if you're going to be in place for multiple hours, I highly recommend that.
And are you one of the Optune Gio buddy? Are you in that program? Are you one of the buddies that talks to people?
I am one of the buddies. I am an official Optune Gio patient ambassador.
Awesome.
And so one of the buddies that gets to do those calls. And it's a lot of
I
fun.
would love, yeah, if I called in, I'd like to talk to you. Okay, so we do have Dr. Golden on standby. I want to thank you, Torey, so very much for sharing really helpful information. If we can, are we at all able to share your information on how to contact you?
It was on that first slide.
Okay.
I
Okay.
highly recommend if you're an Optune user and want to talk to me as a buddy, I think you can specifically request that through the NovoCure site. I am happy to answer easy short questions via my
Okay.
email that was listed on the beginning though as well.
Awesome. Okay. Thank you so much, Torey. All
Thank you for
right.
the opportunity to talk, Delanne.
Oh, yes, we'll give you lots of opportunities. You're great. Thank you. Dr. Golden specializes in neuro-oncology at Oxford MD Anderson Cancer Center in New Orleans, Louisiana. She works to provide personalized attention and the most advanced treatment options available to patients and actively participates in cutting-edge clinical trials, offering patients the opportunity to benefit from the latest therapies. She studied at Vanderbilt University, the Emory University School of Medicine, and as a resident and fellow of the University of Colorado School of Medicine. She also serves as a senior lecturer of neurology at the University of Queensland Medical School. Dr. Golden is speaking on behalf of her clinical experience and not representing the opinions of Oxford Health System.
So I will be talking about Optune Gio, more from a science perspective and timing perspective. Thank you so much, Torey, for all that direct patient information. I love hearing patients' experiences with Optune Gio, and I especially love the trick about working up a good sweat on the days of array changes. That's really helpful. See if I can get my slides to advance. Here we go. To start, most of you, I'm sure, know what glioblastoma is. To make sure we're all on the same page, glioblastoma or glioblastoma multiforme, shortened to GBM, it's a type of primary brain cancer. And what that means is that these tumors start in the brain. They don't start somewhere else and then spread to the brain. And 99% of the time, they stay within the brain and they don't spread elsewhere in the body. It's the most common type of primary brain cancer in adults. Glioblastoma, in terms of overall cancers, is fairly rare, but like I mentioned, in terms of brain cancers, is the most common. It is more rare than things like lung cancer or breast cancer, but there are about 12,500 new cases of glioblastoma in the United States each year. So if you are diagnosed with this, although it's a rare tumor, you're definitely not alone. When we're talking about the use of Optune Gio and other treatments for glioblastoma, we're often talking about different times of treatment. The first time of treatment is right after you're diagnosed with glioblastoma. Other times for treatment is if the glioblastoma unfortunately comes back and is growing again. To go over some vocabulary that we'll be using today, when a glioblastoma is first confirmed by your doctor, that's called a newly diagnosed glioblastoma. Even after 1 or 2 years, as long as your tumor hasn't come back, it's still called a newly diagnosed glioblastoma. That's compared to recurrent glioblastoma, which is when that tumor has come back after a period of time, and you can see that tumor growing on the MRI. The reason that glioblastoma returns is because even if you have the best surgery, the best upfront treatment, we know that there's always going to be some microscopic tumor cells that are left behind in the brain. And because glioblastoma can be pretty aggressive, those cells can sometimes wake up after that initial treatment. And it's difficult for all that treatment to reach every single glioblastoma cell. Let's get into talking about Optune Gio. Optune Gio is part of both treatment for newly diagnosed glioblastoma as well for recurrent glioblastoma. What's really nice about it is that it's what's called non-invasive, meaning that it doesn't involve things like a surgery. It doesn't even involve taking a pill. It doesn't involve an infusion. It's a portable treatment. Like Torey was mentioning, you can take it everywhere you go with you. The only thing you can't do is get it wet, so no scuba diving while you're wearing it. And what it does is it delivers what's called tumor treating fields directly to the glioblastoma tumor site through this portable device and the arrays that adhere to the skin. The way that it works is that it uses what's called alternating electrical fields. Those aren't something that you feel while you're wearing the device, but what it does is it disrupts a tumor cell's ability to divide. And when you stop the tumor cell's ability to divide, you prevent the cancer from growing as quickly. Since healthy cells are different than cancer cells, their division rate is different, their electrical properties are different, they're not affected by the Optune Gio. This is a nice slide that has a good visual aid for how Optune Gio works. So this is showing in the first box there, a tumor cell. The second box is showing you a tumor cell that's starting to divide. And the third box is showing you how when tumor cells are dividing, it leads to more and more tumor cells, which leads to tumor growth. What Optune Gio does is when it's turned on, again, it creates those wave-like electric fields called tumor treating fields. And those tumor treating fields don't allow that cell to divide the way that it wants to. And scientifically, when a cell is trying to divide and it's not able to, it goes under a process that's called apoptosis, which just means that the cell dies. Optune Gio is designed to fit into your everyday life. I love all the pictures that Torey shared of him wearing his, doing a lot of things. It's portable, so you can use it for your normal daily activities. You can wear them fairly discreetly, so you can wear a hat over the arrays or even a wig. There are 2 bag options that are provided for carrying the device. There's a sleeve bag that you can use in what they call a convertible 5-in-1 bag, where you can wear it a lot of different ways for on-the-go use. Based on the studies that were done on Optune Gio, it's recommended that it is turned on and delivering treatment for at least 18 hours a day, which if you take a 24-hour day, that's about 75% of the time. What we've seen in clinical studies is that patients who spend more time using Optune Gio have extended survival. Because of the clinical data of the 18 hours per day providing kind of the maximum benefit and going above 18 hours a day as well, that's where we get that kind of usage goal of 18 hours per day. Let's talk about the efficacy and clinical benefits of Optune Gio. For newly diagnosed glioblastoma, this was FDA approved in 2015 for use. When you use Optune Gio for newly diagnosed glioblastoma, it is an NCC in category 1 preferred treatment, along with radiation and a chemotherapy called temozolomide. NCCN is a group that creates guidelines for cancer treatment nationally. And so the upfront treatment standard for newly diagnosed glioblastoma is a combination of radiation, chemotherapy, and Optune Gio. If you have a newly diagnosed glioblastoma, again, you would first have a surgery, radiation and chemotherapy together, and then you would start the Optune Gio along with the chemotherapy. For recurrent glioblastoma, again, which that means if the tumor is growing back on your MRI, Optune Gio has been studied alone once other treatment options like surgery and radiation have been exhausted. Another thing that's great about Optune Gio that I like to tell my patients about is that because it's not a chemotherapy and because it provides local treatment, there aren't the typical chemotherapy-related side effects. And so the device is used with chemotherapy, and so there are some reported side effects of things like, nausea, loss of appetite, fatigue. In my experience, it seems that those side effects are more related to the chemotherapy itself than the Optune use when those are being used together. Unlike other chemotherapies, it doesn't have a combination effect with the chemotherapy that's prescribed for glioblastoma, meaning that the use of Optune Gio along with chemotherapy does not worsen the side effects from chemotherapy. There was the large clinical study that I mentioned back in 2015 that led to Optune Gio being approved for first-line treatment for glioblastoma. It showed better survival rate for patients who used the Optune compared to patients who didn't. My favorite data from this study is this 5-year survival rate, because when I talk to my patients, yes, people care about being able to extend their survival by even a few months, but everyone wants to be that long-term survivor. They want to be the person that lives a long time, even with this diagnosis. And in the study, what they found was that patients who got the standard upfront treatment with radiation and chemotherapy alone had about a 5% survival at 5 years, meaning 5% of patients were alive 5 years after diagnosis. When Optune Gio was added to that, there was a 13% survival rate at 5 years. So more than doubled that rate. We mentioned a bit that Optune Gio does not have additional side effects along with the chemotherapy. It doesn't worsen chemotherapy side effects. The main side effect with Optune Gio use is scalp irritation and headache. Other side effects that are listed, such as malaise, falling, twitching, in my experience, I attribute those often more to the chemotherapy that's being used with the Optune Gio than the Optune Gio itself. The main side effect that I see in my patients, in my experience, is the skin irritation, which can include dermatitis, which is red, inflamed, swollen, flaky skin, what's called folliculitis, which is inflammation of a hair follicle that can look kind of like a pimple, and erosions, which is where you lose the outer layer of skin and you have a little bit of an indented sore. So how do you incorporate the Optune Gio into your daily life? I talked about trying to wear the Optune Gio for at least 75% of the time, and Optune Gio can be given almost anywhere. I have patients who wear Optune Gio at work. I have patients who travel with Optune Gio. I have patients who go to weddings, graduations while wearing it. The transducer arrays need to be applied directly to your scalp to work properly. And I know Torey went over his kind of shaving routine and how he preps his skin. In order to wear the Optune Gio, you do need to shave your head so that those arrays can be right up against your scalp. And then to prevent the transducer's arrays from getting wet, if you're not changing your arrays that day, you would cover them with a shower cap while bathing or showering. One thing that's great about Optune Gio is that the company Novocure has this My Novocure, which is both an app and a website and a phone number you can call. And My Novocure has been really helpful for both me and for my patients. From my side, when I prescribe Optune Gio, it goes to My Novocure and they help sort through any insurance support that's needed or any financial aid that might be needed for patients in the case of insurance not covering as much as we'd hoped. They also take the lead on reaching out to the patient on bringing the Optune Gio device to their house and showing the patient and their caregivers how to use it. They have a lot of tips for integrating Optune Gio into your life, resources for when you're traveling, as well as treatment information and troubleshooting. Like Torey mentioned, Optune Gio also has a buddy program, which is another part of the My Novocure that I love. I can tell you all day about Optune Gio and what it's like and what the data is behind it, but I've never worn it myself. And so I love that there's this opportunity for patients who are using or considering Optune to talk to someone else who's going through what they're going through and who's actually using the device. Novocure also has webinars for Optune Gio. It's another way to get more information about the Optune Gio and potentially meet other users that are wearing the Optune Gio. These are some QR codes and some websites that are available for you to learn more information. That is what I have.
Oh, awesome. Thank you, Dr. Golden. Yay. Yes. Yay. Yay. We have some questions that have come in during this webinar, as well as a couple of questions people asked when they registered for our webinar.
Great.
So we have some people from Africa and India asking, is the Optune Gio device available outside of the United States?
That's a great question. I know that there are countries in Europe where it's available. I'm not sure about India. I'd have to ask the Novocure team.
For the countries you do know that it's available, are you able to say some of those countries or?
I believe it's available in places like Spain, France, and Switzerland. Outside of that, I'm not sure.
Okay. Okay.
I believe Germany and Japan. I know there are Novocure offices in Germany and Japan, as
Great.
well as Switzerland.
Excellent. But, you know, there's people worldwide, it sounds like, looking to have availability to this device. And that's something too that we can share with the Novocure folks and then kind of maybe find out where they're at in that process of doing that. So keep us in mind for finding out more information related to other countries in the United States and where Novocure is at as far as having it available. Oh, this is a good question. Dr. Golden, related to the Trident clinical trial, do we have any results yet?
I'd have to defer to the people who are running the trial on that.
Okay. Okay. And so Shreya, our patient navigator and clinical trial coordinator, can work with the PI on the Trident trial and find out the answer to that question. So we'll get back to you, okay? You covered this a little bit, but someone has written in, is there any data on the survival rate of Optune Gio alone?
Yeah, that's a great question. For newly diagnosed glioblastoma, there is not. And that's because we've had so many other clinical trials that show that surgery, radiation, and chemotherapy do so much better than nothing else. And so to build a trial where a patient is not offered a standard treatment like that, it becomes an ethical issue. In terms of recurrent glioblastoma, the way that Optune Gio was studied for recurrent glioblastoma was by itself. So they compared Optune Gio versus physician's best choice chemotherapy. And what they found was that the outcomes were about the same between the two.
Thank you very much. Torey, thank you for answering some people's questions that they're directing towards you as well. Thank you. This is an interesting question. What is the efficacy shown with TTFs and how are they affecting overall survival?
Yeah. So what the study shows that looks at newly diagnosed glioblastoma, which again is looking at people who got surgery, radiation, and chemotherapy alone versus all of that plus the Optune Gio. The data shows that the overall survival increased on average by about 5 months. The 5-year survival rate increased from 5% to 13%.
Thank you. Thank you. I have another question and I'm not exactly sure how to ask it because it's from a patient from New Hampshire. And it says Optune outcome studies, immunotherapy for glioblastoma. I'm wondering if they're asking if there are any Optune studies utilizing immunotherapy for GBM. I'm wondering.
There is a study that's going on that's looking at Optune with pembrolizumab, which is an immune therapy. That trial is still going on.
Do you know the name of that trial?
Oh, I don't remember the number of it off the top of my head. It's
Okay,
EF,
that's okay.
EF something.
That's okay. Shreya can find it out. Now, this is an interesting question. Why isn't Optune Gio the standard arm for most current clinical trials?
Yeah, that's a really great question and a point of contention with some people. I what I've seen is that now that Optune Gio has that NCCN preferred treatment designation, that clinical trials are becoming a lot more open to having Optune as part of the standard treatment arm. I think it's a slow transition. What I've seen in my experience is going from either you can't use Optune during this clinical trial, we're not quite to you have to use Optune during the clinical trial. We're kind of in between, where sponsors are saying you can use Optune if you want to, and you can still be in this clinical trial.
Thank you. Thank you. And a great question, of course, Optune Gio, is it covered by insurance?
Yes, it is.
Yes. There's been a lot of hard work, advocacy work behind that. And I can tell you it is covered by insurance, finally. Thank you, Dr. Goldman, so much for spending your afternoon with us and educating us. And
Thank you.
I appreciate your work with this patient community. Thank you so much.
Yeah, thank you for having me.
Absolutely. Thank you. I want to introduce you now to Dr. Anik Desjardins. And thank you, Doctor, for joining us today. It's a little bit later on your end if you're anywhere near Duke. Dr. Desjardins, she's a professor of neurology and professor of neurosurgery, and she is the director of clinical research for the Preston Robert Tisch Brain Tumor Center at Duke. Her primary focus is patient care and clinical research as a neuro-oncologist. Her clinical research focus is providing innovative and aggressive therapies to adults with primary brain tumors. She always keeps the patient's quality of life foremost in her practice. She completed her residency in adult neurology at the University of Sherbrooke in Quebec. She finished a 2-year fellowship in neuro-oncology at the Preston Robert Tisch Brain Tumor Center at Duke. And upon completion of that fellowship in 2005, she joined the center as faculty. She is a fellow of the Royal College of Physicians of Canada. Dr. Desjardins, thank you so much for joining us today. I'm super excited about your presentation.
I'm excited to be back presenting at the End Brain Cancer team. They're fantastic. I remember being there in person in 2016. So to meet all of you by the webinar is really exciting for me. So I wanted really to talk with you, and it goes well following Dr. Golden, because Dr. Golden mentioned something very important with the Optune Gio about the fact that we prevent complication from what we call systemic complications, of complication from taking a chemotherapy by the mouth or intravenously. So this is also type of things that we try to do, that really I'm focusing my research on how to really go where the tumor is and try to prevent other side effects. So today, what I want to talk with you about is really our novel immunotherapy delivery technique. So how do we get our medication or new treatment into glioblastoma patient and really have the maximum efficacy? Here are my disclosure. And really talking and why it's important, right? Really thinking about, if you look at this FDA approval in primary brain tumor of the different agent, we really don't have much approved for glioblastoma. The last couple of years, we have seen approval of new drug for per medication or tumor with specific mutation, the V600E that are mostly seen in children with brain tumor, the SEGA, and then the recent approval of IDH inhibitor, so vorasidenib in August of 2024. So all big discovery, but really in glioblastoma, if we're thinking about glioblastoma, lomustine, carmustine was approved in the 70s, then we had Gliadel, and then the temozolomide 2005, bevacizumab or Avastin 2009, and then the Optune Gio, I still had it under, Novo TTF, really approved, just beginning of 2010. But really since then, no significant approval in our brain tumor patient. Why is it hard? Most of you, I don't need to tell you why it's hard to treat brain tumor. Really, as we know, this is a tumor that is really infiltrative into the brain. It is really hard for the neurosurgeon to get a complete resection. And there is this whole issue of the blood-brain barrier. And here is a really example, what is the issue when we talk about the blood-brain barrier issue and our drugs not being able to reach the tumor, all the tumor. is really, this is a great example. So you have here a case, right, where the patient had surgery. This is what we see of the enhancement, the contrast enhancement. And then what you can see, however, so you think you remove, the surgeons are able to remove this. But if we look at what we call the flare images, where we would say we see the edema, but really the edema for us is an indication, where is that infiltrative disease? And all of that, the surgeons just cannot go and remove that. So there is a lot of the tumor cells that we just cannot reach right now with our treatments or with the surgery. Because the other issue we're facing, this is highly heterogeneous tumor, meaning that even inside the this area of tumor or a little farther, where is the infiltrative disease, the genetic makeup, the mutation of the tumor are very different, and they're very different from patient to patient, but also different inside the tumor. And the issue of really that the fact with the blood-brain barrier, with this diffuse infiltration, we really call tumor cold tumor, meaning that there is not a lot, the immune system really cannot see our brain tumor. They cannot see GBM. It's just hiding behind the blood-brain barrier, which is very different than other tumor like melanoma, lung cancer, that have like great success with the novel immunotherapy, like the checkpoint inhibitors. And then another thing that for me is always very important is the fact that our brain is who we are, right? That's our computer. That's really what makes us us. And then the impact of the tumor on our day-to-day functioning, on the loss of wages because we cannot work anymore, on the need for our caregiver to be there, right? As also a very important impact that makes it hard to treat brain tumor. You have heard today about like different treatment. We just heard about the Optune Gio, and I know earlier you had other therapy, but really one thing that we're focusing on is really immunotherapy. So instead of using high dose radiation, high dose chemotherapy, how can we activate the immune system? How could we build in how I describe it to the patient? I always say it's like if we have our own little built-in Pac-Man, how to activate them to look for the tumor. And there's different forms of immunotherapy that are being tested, the checkpoint inhibitor, different vaccine, viral therapy, CAR-T therapy, tumor-infiltrating lymphocyte, antibody toxin conjugates, a lot of different immunotherapy. And I'll talk about, right, the ones we're focusing on or that I'm focusing on at Duke. My colleagues are working on others. But really, and what are some of the limitations and how we're working around it. One of the things that is clear is, I mentioned, so checkpoint inhibitor is a form of immunotherapy that is used, that as I mentioned, has had great success in other cancer. This is an example of lung cancer, where when they did the study in lung cancer patient, right, really showed that compared to standard chemotherapy, when you added the checkpoint inhibitor, you clearly improved the survival of patients. The problem with those checkpoint inhibitors, they're given intravenously. They're called antibody, which means that they're big. They cannot really reach the blood-brain barrier. And we have tested it, and this is one of the study, right, where it was tested against bevacizumab. And we have tested it also against radiation and temozolomide, the standard of care. But really in brain tumor patient, because of the issue of reaching the blood-brain barrier, because of the issue of having very little immune cells inside the brain, we have really not shown any efficacy right now with the checkpoint inhibitors trial. We're looking now at combining it with other agents like, right, the vaccine, the CAR-T therapy, right, the oncolytic viruses. But so far, right, the data we have is that really has not created much benefit to our patient. So what we have been working, really what I've been working the most on since, in fact, 2012, is really of how to get drug directly to the tumor, right? How to get a new agent. So this is the new delivery technique, right, I was mentioning. So instead of giving the drug intravenously, instead of trying or by the mouth as a pill form, how to just like infuse it directly into the brain. And you can do that different ways. There is some that would use, do the surgery and inject the medication in the wall of the surgical cavity. We decided to go a little differently, and instead of like more to mimic how fluid normally works or travels into the brain, what we decided to do is really use a technique called convection enhanced delivery. And what convection enhanced delivery means is that when you have a tumor regrow, hernia, or we're working now toward going for a new tumor, the surgeon can put a tube, a little catheter inside the tumor, which is very similar to what they will do if they were to do a brain biopsy. So they inject a tube, and then we slowly infuse. So we infuse at a rate of, we call 0.5 ml per hour. So it means that a teaspoon, right, 5 ml will take about 10 hours. So we slowly infuse the drug to really mimic how fluid works and travels into the brain. And the advantage of that is really, our goal is to try to coat as much as possible of the tumor cells with our drug, with our agent, and to not disturb as much as possible the normal anatomy of the brain, so not trigger seizure, not trigger headache, but slowly infuse our drug. And then when it's removed, we remove the catheter. So this is, right, a convection enhanced delivery. So we insert a small catheter in the area of the brain. There is a pump that slowly push very carefully the medication. And the cool thing about that is, right, we're doing the trials here at Duke right now, but we're not the only ones that use this technique. And because it's really similar than just doing a regular brain biopsy, once we get a drug that we show will be effective, this can be repeated pretty much anywhere where you have a brain neurosurgeon that knows how to do brain biopsy. And this is really an example of one of our patients where what we did here is really, so this is the hole from the surgery. You can see in the bottom, this is an MRI without contrast. You can see at the bottom, that's where the tumor is. The catheter is in place. And what we did with this is that we mix, instead, in fact, of then giving the contrast intravenously, like we normally do when you get a brain MRI, what we did is we mixed the gadolinium with the study agent that we infused to really show that by infusing back the catheter slowly, we can really coat the tumor with our study drug. We have tested, so the convection enhanced delivery, so I was telling you, I've been working on that now with our neurosurgeons here at Duke now since 2012. We have treated over 360 patients. We have treated with this technique. You might have heard about the genetically modified poliovirus. The new name is called larabultarev, so use polio. We have other agents. This is using what we call the Pseudomonas exotoxin. We have used CAR therapy, and we have collaborated. We had worked with different companies that have also had us test different agents that we inject directly into the tumor. So I'll give you a little bit of data on, or show you, right, where we started, where we are today, and then also like where we're moving forward to. So, so this is the data on the poliovirus. And in 2016, when Dylan and me come meet the team in person, really, we had talked about that. And in fact, Stephanie, our first patient, was with me when we went, but really showing that when we did the genetically modified poliovirus trial, in that trial, what we were doing is the patient had one single tumor growth. We were putting the catheter inside the tumor. We were slowly infusing over 6 hours the genetically modified poliovirus, pull the catheter, and that was it. Patient were getting one single treatment, and then the tumor will get inflamed, angry. This is an immunotherapy, so you're faking an infection. It gets angry, gets inflamed, like if you're having, something that gets infected. And then with time, the immune cells just destroy the tumor and it just contracts. In those patients, right, the study here, so that was published in 2018, really what we showed as part of the study in our glioblastoma patient, if we look at the red line is the patient that were treated with other trials versus the blue line, the GBM trial. So this was a single brain injection. And really what we showed is the patient, the drug, the single brain injection was not working great for the patient that the tumor was growing really fast or had very weak immune system, but we still had this group of patients, 20% of patients that became long-term survivor after tumor regrowth, where really normally you're told if your tumor comes back, right, there is very little chance that we'll be able to talk about long-term survival. But we were able, by a single brain injection, to have 20% of patients that became long-term survivor. Of course, that's not acceptable, right? Every single day I meet with patients and family like yours or like the ones you're taking care of, and we need to help more than 20% of patients. So really what we have been looking at for years is how can we retreat patients? How can I be able to infuse in the brain multiple times the virus and do it safely? And the team in Japan, so Dr. Toto has published that, was able to do it where what he did is every couple of weeks, every couple of months for 4 to 6 doses, he went in and he injected the virus, which he could do safe, which he showed it was safe. He was able to retrieve the patient. The problem is it's hard in the United States to get that paid for. You would need to have your insurance company agree that we put we bring you back to the operating room every 2 weeks or monthly to get a brain injection. So you can imagine that would be extremely expensive. And then the risk, the trauma. So we said, okay, that's feasible, but how can we do it better? The other reason why we wanted to do that is what we had realized is in our poliovirus patient, I was telling you 20% of patients became long-term survivor. And in those patients, when their immune system got weaker and the tumor came back, so you can see this patient, the tumor was in remission for 70 months, this one 35 months, this one 60 months. When the tumor came back, we did a second brain injection of the polio and it worked again. It gave again the patient, right, 12 to 20 months, which is much better than the data you will expect normally. So all of that, I've been talking a lot just to say, so we have figured out with polio that in fact, if I was able to put the catheter in and do double brain injection only 4 days apart, I don't need to wait the 2 weeks or the 1 month that Dr. Toto, the team in Japan did. Really, if I put the same catheter, and this is the animal data, we put a catheter in, we inject inside the tumor, we leave the catheter in place, and we inject a second time 4 days later. And this is really just to show, so this is the animals without polio, this is the animal with 1 brain injection. This is like how much we help with double brain injection 4 days apart. So really we have figured out a way that we can treat the patient twice, trigger a better immune response, and really without having to bring back the patient to the operating room, without triggering a new bill to the insurance company, without triggering an additional trauma to the brain. And that's what we're doing right now. So we have a trial. This trial is now started, where really what is happening is our patient at the time of tumor regrowth, the catheter is inserted, and we leave the catheter in place for 4 days. We do first injection, normally it's like on a Monday, 6 hours of the polio, we leave the catheter, we just put a bandage on it. And then on the Friday, we do the second brain injection of 6 hours, and then we pull the catheter out. And really, we should see the same thing of long-term survival in the patient, that, improvement compared to single brain injection. That again, single brain injection, 20% of the patient had benefit. By adding the second brain, what we expect is we'll have much better improvement. The other thing also that we figured out, and I will talk with it on the next slide, is really the fact that I was telling you, right? Checkpoint inhibitor don't work great in brain tumor patients. They just don't cross the blood-brain barrier. But really what we have figured out is that in the neck, we have lymph nodes, and the immune cells that goes attack the tumor are living in the lymph nodes of the neck right there. And so what we started doing is that we inject our medication in the brain, so the double brain injection with the polio. And then after that, instead of giving an intravenous checkpoint inhibitor that cannot cross the blood-brain barrier, in fact, what we do is we go and we inject those checkpoint inhibitors. So we have, it's called an anti-CD40, and I'll show you some of the result, or the poliovirus in the neck area every 3 to 4 weeks. And really the goal of that is I'm triggering the immune system to start attacking the tumor in the brain. But then after that, I'm keeping the immune cells alive, active, by injecting around the lymph node and telling the immune cells, you need to stay awake, don't die, don't give up, keep going into the brain and fighting the tumor. And so this is a trial. In fact, we have already been going, and I showed the data, right? This is another one of our agent that we inject in the brain called D2C7, and we do, so the patient get the brain injection similar to the poliovirus. And then after that, we start once a month. We just changed that to once a month, the injection around the lymph node, and really showing that those patients that were glioblastoma patients, that when the tumor comes back, we expect that the survival is normally about 6 to 8 months. We had patients, right, that we were still treating patients, so patients that are still early, but patient at 20.6 months still doing really well. Patient able to get up to 23. Now it's more than that. Like I have patients that are more than 27. Injection in the neck of the checkpoint inhibitor, their immune system stays strong, they remain in remission, and there is no bad reaction. I know I'm running out of time, but there was another cool thing
You're
that I
okay.
wanted to talk about. Huh? I'm going
You're
to,
okay.
okay, it's my last slide. But another thing, so we're excited. We can treat in the brain twice with one brain procedure. We can keep the immune system active by using the lymph node instead of intravenous. The other thing also that we're super excited about is we are collaborating with this group called XVADE. So I call it the tumor monorail team. They came up with this little catheter, and some of you, if you have heard about an Amaya catheter, so it's a small catheter similar to the Amaya that we can put, this is an animal, we can put the catheter in the tumor, and it pulls, you see, in the animal we can do it because we can get, right, close MRI, but we can pull the tumor inside that reservoir and collect it. So what is happening? So the catheter is lined, but this fiber, it's a nanofiber that will pull the glioblastoma cells inside. And we have now treated our first patient where we have put the catheter in. What is the usefulness of that? Is that now it's allowing us to sample the tumor without having to go back. We can just put a needle in that small reservoir right there and collect tumor cells directly. So the tumor cells, the tumor fluid is growing into the catheter, and we can collect the tumor cells in this reservoir and know, is our patient responding to the immunotherapy? Is the immunotherapy given up? And not after repeated brain biopsy. So we're really excited about that because that's really a discovery. The patient is tolerating really well, and we are able, we just a little bump, really nothing we can see under the scalp, but it's allowing us to sample. So I cannot give you what we're collecting right now and what is representing, but so far we are able to see tons of protein. We're able to follow over time how it's changing, how it's responding to the immunotherapy, and when the immunotherapy gives up and why it gives up. So in conclusion, I mean, we all know it. That's why we're here, right? We need to help our patient. I'm super excited on how we're continuing to work and developing new therapy, how to go directly to the tumor, how we can try to minimize having also to bring you back to the operating room. But at the end, right, is really just everything the patient do. And thank you, to all of our patients. I must say, all of my patients, the main thing they say is, I'm afraid I'm not giving you enough data. I'm not helping enough the next patient. So again, thank you to all our patients, their caregiver, and from the whole team. And this is the Duke team. So thank you. I hope this was useful and interesting. Thank you.
Thank you so much, Dr. Desjardins. There are a couple of questions. Are you available to answer some of those?
I am, absolutely.
Oh, can you tell us about how to increase efficacy of dendritic cell vaccines, especially unmethylated GBM?
Oh, this is a great question. So we're looking at that. Yeah, the dendritic cell vaccine. So we're looking at different options, right, with the dendritic cell vaccine of how to increase the efficacy. The same way we're looking with the virus. I was telling you, about virus today, but removing the tumor, adding a chemotherapy first to maybe, right, make the tumor, I'll describe it to the patient, make the tumor weaker, right, and less aggressive, or eliminate, what we call the bad immune cells, the Tregs. There is different way of adding the checkpoint inhibitor. That's where I was showing you the data where the checkpoint inhibitor on its own doesn't work better than just radiation chemo or, Avastin. However, when you combine checkpoint inhibitor with dendritic cell vaccine, will it help? So there is lots of different ways. We don't have the answer yet the same way, right? I always say this, the way I describe it to the patient, right? It's really a stepping stone. And I showed you a few of the stepping stone that we have done in the last 12 years with some of our agents. But it's the same thing that is happening that we're doing with the dendritic cell vaccine, all of our immunotherapy.
It's very exciting. I'm really excited about the tumor monorail device.
I'm
That's
really excited.
and
And I can tell you the first patient brave enough that did it is really excited too. It is really cool.
question. I think it's related to the polio trial, but I'm not 100% certain. What was the recurrence percentage within the 20% of long-term survivors?
Yeah, so the answer, right? So the 20% of long-term survivors, so you saw some of them recur right at like 70 months. So not all of them have recurred. A number of patients are still in remission at this point. We're still following them. A few of them, the tumor recur at some point, but as you saw, as we retreated, they benefited again. I think the question is more, right? We know not only glioblastoma survival at a recurrence, we're talking not in years, but we're talking in months, and really figuring out how we keep getting the immune system active. And that's what we're hoping we'll do with the injection at the lymph node of the neck. So I don't have the number because we still have many of them that are still in remission, to be honest with you. But I would say probably like half of them, we have to talk about other treatment at some point, but it's still better than, 20% at 3-4 years still alive was, in remission was still much better than what we had seen in the past. And some of those patients made it 7-9 years at this point.
Which is fantastic.
CMV CAR T is promising. Yes, CMV, all of the CAR T, right? The problem with the CAR T therapy. I'm sorry, Dylan, I jumped on it.
No, you're good. You're good. You're great.
All the CAR T therapy, right? We're all excited about it. I'm sure you saw the great result, right? The team at City of O, Pittsburgh, right? Mass General has great data on that. We are reworking ours. The issue where all of us have the CAR T is really, it works really, really good at the beginning, but then rapidly our body develop antibodies against it. So we fight the CAR T. So how can we make it persist longer? So that's the next step. How to keep the CAR T therapy longer in the brain, which is a little different than the approach with the polio that we were talking about, because the polio is we're not giving you an immunotherapy that we grew in the lab. We're more like activating your own immune cells.
Related to the polio virus, yes, it's still available at Duke. Where else in the United States is it available?
Yeah, great question. Unfortunately, right now, just because of funding, we have been obligated to close the other sites. We didn't have, unfortunately, the money to keep open the other sites. So right now it's only at Duke. We are, of course, looking at how to get more funding. So we want to bring it back, right? That we did the study with the team at UCSF, Mass General, Dana-Farber, Cleveland, Hospital Cleveland, Jacksonville, Florida. So we had done the phase 2 multi-site trial. We were able to prove that they had the same result as us, that 20% of the patient became long-term survivor with the double brain, the one brain injection. So yeah, we're looking at the funding to bring the double brain injection and the injection in the neck to the other side. Money.
Fantastic. Is that like NIH funding?
Anything, we're open to anything.
Okay, all funding options.
Any funding. Right
This
now,
is-
the trial is open at Duke based on a generous donor philanthropy.
Oh, okay, fantastic. This is the last question just because of the timing. I want to ask you this question because this is from a patient who resides in near Duke. You decide how you want to answer it. And then I feel like I'm going to put this patient in touch with you.
Okay.
I'm having surgery on May 20th for a biopsy. I'm unsure if it's cancer right now. What should I prepare for? I understand now that preservation of tissue is important if it's malignant. I'm going to say it's important even if it's not malignant. What should I request my surgeon does? Should I have the surgery or wait, or maybe be seen by a different specialist, neurosurgeon, that would be recommended to them? That's a question.
It is a loaded
It's a
question.
big question.
It is a big question. So I think that really having the conversation, right, with a surgeon is really important. You feeling comfortable with your neurosurgeon, it is for sure that you want to understand the risk, and you want to make sure that the tumor, right, that is removed, that it's sent for all the testing possible, also to get all the genetic, right, the sequencing on the tumor. So yeah, Dylan, I think that's the only thing I'll answer. Please, more than happy to help.
I'll put you guys in touch.
Yes,
I
thank you.
actually do have one more question. I think I know the answer, but I'm not 100% certain. Convection enhanced delivery, CED. It's the slow delivery. Is that done in the hospital setting, or can that be done, outpatient?
Yeah, no, great question. We have a trial where we injected one of the multiple agent I showed there that we were able, in fact, because we were able to inject it in the outpatient setting. So it is now, we are working on that. We have another protocol right now that we're bringing in, that we're just starting, that will also allow injection at home. So the answer is yes, it's in the work.
Awesome. That's
Yep.
wonderful. Keep us posted. That is incredible.
It's really exciting.
Thank you,
Thank-
Dr. Desjardins. It's so good to see you. I want to
Yes.
say Dr. Desjardins is also on our medical advisory board. We thank her so much for her passion for her patients and her research, and all the help she's provided us along the way as well. So thank you. Keep
Thank
up
you.
the
and,
great work, my friend.
Thank you. You too. Thank you. Thank you, everybody. And thank you, the whole team and the Hand Brain Cancer. I appreciate it. Thank you.
Thank you. Okay, you guys, it's pretty exciting. Right now, it is time for our 2025 National Hope Award program and presentation. This is a program that's really a patient disease education awareness and outreach program that has been supported for many, 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 many years by Novacure. So I want to say thank you to Novacure, because this is such an important program. The education that comes out of this programming and the awareness and the outreach and the distribution of the campaign, there's always educational elements put into that for patient education. And the idea of the National Hope Award is really for other people to nominate in the United States that particular GBM patient, that patient that has glioblastoma multiforme, who is inspiring others with the way that they're living their life, the way that they're fighting this disease, the way that they're approaching everything in their life. And so people write in and they nominate people within their life who are have GBM. And we get to read about an awful lot of people that we might not know about, but we read all these incredible stories about people who are doing amazing, inspirational things. Our last year's recipient is Patty O'Donnell. He is a amazing young man, ex-collegiate hockey goalie, and I've had the pleasure of actually getting to meet Patty several times in person and his family, and he's inspiring every single time. And well, he won our award last year, and he continues to inspire an awful lot of people, and his story is up on our website, and there's been a press release, there's been news coverage. I had the privilege of presenting him his award last year via Zoom, but then later on in the year, I had the privilege of presenting it to him in person. So Patty, keep up your great work and your inspiration. He says that fighting GBM is a mental game, and you must have hope every single day. So thank you, Patty. And now it's really fun. We get to show you and introduce you to two runner-ups of this year's campaign. And I think we have a video that we're going to show. Is that correct?
When Sabrina was 30 years old, she developed chronic headaches that were diagnosed as GBM. She pursued aggressive treatments at the Duke Cancer Center and continues to survive and thrive for 23 years and counting. During her cancer journey, Sabrina was married, had a daughter, and watched her daughter grow up. She is a fountain of hope for all those battling this disease. Ben Williams, a professor of experimental psychology, was diagnosed with GBM in 1995. He put his scientific training to good use in researching this disease and worked with his medical team to develop a treatment plan. He wrote the book Surviving Terminal Cancer, which chronicles his journey. This book served as the basis for a documentary video on cancer treatment. Ben is alive and well and continues to provide hope to GBM patients. Peter was diagnosed with GBM in 2018 at the age of 34. He faced a number of challenges during his cancer journey, including a recurrence of the GBM in 2020 and a house fire. Throughout it all, he remained hopeful, and his motto is "Go with the good." Peter started a nonprofit with the same name, which is focused on providing financial aid and supportive information and resources so that those affected by advanced brain tumors can focus on the treatment, recovery, and quality of life. To date, the Go with the Good team has touched over 100 brain tumor patients.
Okay, that's pretty exciting. Everyone honestly should get a Hope Award, to be honest, because there's so many. Every patient is inspiring in their own way, and they're inspiring their networks, their doctors, families, and their friends. And as advocates, they inspire us also so very, very much. I know Ben Williams personally, and I will tell you, he's very inspirational. He's doing well. We have about 10 of his books that he has provided us. So if anyone would like to have a copy sent to them, please let us know. You can capture it in the chat if you'd like, or you can, of course, get a hold of us at the End Brain Cancer Initiative. We'd be happy to send that book out to you. And when we deliberate over who on earth should receive our Hope Award, our National Hope Award every year, it's tough. But we would like to announce this year's award-winning recipient, and that is Peter Meng. Peter, his wife nominated him. Congratulations, Peter. His wife, Kate, nominated him, and like you heard, his motto is "Go for the Good." And I love that they started a nonprofit that helps patients. They also are fundraising, and they also provide some financial support as well for patients who have GBM and their families. So feel free to let us know if you'd like to be put in touch with them. And he was actually diagnosed when he was 34 years old in 2008, and he had a recurrence in 2020, and he's doing great. Look at him. He's thriving, he and his family. So our 2025 National Hope Award goes this year to Peter Meng. So congratulations, Peter. We have an amazing video of Peter Meng and his wife, Kate. And this was recently created when he learned that he was going to be one of our runners up and potentially win the National Hope Award. So could we play that video now? Thank you so much.
This is 2018. I was in my new job for just over a month. Everything was fine. Everything was good. At one point at work, they say I just started saying weird things. So they realized something was wrong, went to the ambulance or to the hospital.
I met him in the emergency room. He had just had several seizures, so he was kind of out of it. I was processing, originally we're like, is this a stroke? Is something going on? found out after the scan it was a brain tumor. And so getting advice from this doctor, he said, nope, you want to switch hospitals. It is a brain tumor clinic. Take better care. So I had to advocate for it. It was not, they did not want to give him up right away.
I mean, they were able to remove what they say 99% of the tumor, which was great, but obviously they had to get in a little further. So there was a aphasia. I couldn't read. I couldn't even find the words. I still remember, like, I'd see a tree and I couldn't find the word of a tree or a bike.
Yeah, he did a lot of therapy to work it back and being able to read again. You
Yeah.
worked really hard.
So the first thing I think about is never giving up, continuing. At some point, I had said, hey, we just have to go with the good, because there's always going to be something bad with things. I mean, to be honest, but there's always going to be good things. And that's where I see hope, is there's always something good, no matter what you see. It can be anything. It could be, we took a walk today, you know, that's a good thing. Or went to the movies. There's always something great, no matter what it is. So I think that's where I connect hope, is with good and continuing on and not giving up with it.
I don't know anyone who's been through so much and continues to choose to act in a manner that is not just good for himself, but for everyone around him.
We know you're not able to be here today, and we know why. Those appointments sometimes take longer than they should, right? But we will be able to connect with you, and we'll be able to present this to you, and we'll videotape it. And so we'll incorporate that into this video presentation. Peter, you are our 2025 National Hope Award winning recipient. So I just want to say congratulations. One, and you will be.
Thank you so much.
Oh, you're welcome. You're welcome. It is like our huge pleasure to provide this to you. We'll be sending this to you and via snail mail. It has your name on it. It has the 2025 date on it. It has our National Hope Award sponsor is NovoCure. It has their logo on it, as well as the In Brain Cancer Initiative's logo on it as well. Because, you know, we get to meet all kinds of people who've been diagnosed with a brain tumor or brain cancer, and we get to be inspired by them. I just want to say thank you to you, Peter, for inspiring not only your wife,
Yeah.
but inspiring so many others with the way that you are living and showing us how to live, right, with this disease and how to fight this disease.
Well, first, such an honor. I really appreciate it, in that this is showing that what I'm doing, you know, it's working, and it's amazing. Every day makes me happy that I'm doing well. So I just keep on going. I know at one point we were just sitting there and I go, you know, there's a lot of struggles, but we just need to go with the good. There's a lot of good stuff. So I was like, we're just gonna always just kind of going with good things, knowing that there's gonna be tough things.
I feel like you were choosing to look for the positive, right? And of course, that's a choice you make, but it's also something you have to pretty much think about every 5 minutes, right? You sort of, you need to live it. You live the example, go for the good.
That's what I enjoy, is waking up and doing the next day.
Excellent. Excellent. And how are you feeling?
I'm doing great. I mean, to be honest, I mean, I'm at doing treatment twice or 2 times a week. I mean, it doesn't slow me down at all.
Peter, and his wife, Katie. Thank you so much for sharing your story with all of us. Katie, thank you for nominating your husband. He is an inspiration, and so are you. And thank you. The In Brain Cancer Initiative truly acknowledges both of you, and we'll be in touch.
Yes, thank you. Thanks for all that you do as well.
Yeah.
I nominated him because I follow and utilize your resources.
Yay!
The reason that I applied is because you made it available, and I was already a fan and have been a recipient of your education.
And again, thank you, NovaCure, for helping to support this effort. It is genuinely appreciated, and it's needed. This patient population needs a spotlight put on them, and they need to be able to inspire freely, and we need to be able to share their stories. So thank you so much. We have Shreya, who is our patient navigator and clinical trial coordinator. She's going to share a little bit with you related to some of the resources that we have on our website and some of the ways she can help you. You just have to reach out to her. And Shreya has put together a slide that she's going to utilize. And you can see Shreya at endbraincancer.org is her email address, and her EBCI phone number is 425-436-8688. So she's available during the day, Monday through Friday, and she also opens up a couple evenings a week also to work with and meet with patients and caregivers and families as well. So Shreya, you are on.
Thank you, Dylan. Today, I wanted to take some time to share our patient resource center. We have some good, fact sheets, very informative information there. I think we should be very good for you guys to see, and a good resource for you, everyone to have. So I have highlighted some of the fact sheets we have on the Patient Resource Center, and then I will share my screen so I can show you where to find this Patient Resource Center as well. So we have, information about immunotherapy side effects. If you have questions about cancer care, so if sometimes patients get overwhelmed and they're like, I don't know what to ask my doctor, I don't know what to ask my nutritionist. So we have, a fact sheet about some of the questions you can ask them as well. And then we also have some information about why should you consider a clinical trial as well. And a lot more fact sheets. So I'm gonna share my screen now. So this is the EBCI website. So this is the homepage. And then if you go to resources, this is the drop-down menu for resources. You can see different resources and stuff which you can explore, but today we'll focus on the Patient Resource Center. So, and then here you'll see different fact sheets. It's always evolving. We are always, uploading new fact sheets, and we are updating the ones we have to make sure it's current with, new treatments that are upcoming as well. So this is a fact sheet that NCCN published recently about immunotherapy side effects. And then they had information about immunotherapy. This is a good fact sheet to have to look at if you are, facing some symptoms, in different parts of your body, and just to, cross-check to see if that's a side effect of immunotherapy, or if it's something else. Let's see, and then I'll go back to the Patient Resource Center. And this is a very good fact sheet that I always tell patients. If you are going for your appointment with your doctor or your care team, if you can print this fact sheet, I think it would be very good to take it with you, because it has questions, about cancer testing, about treatments, about clinical trials. And it's very patient-friendly questions also, which you can just ask your doctors, or just use this as a guiding tool to ask questions, to frame your own questions. And then it also has space to, write down notes as well, what your doctors tell you. So it's just a good thing to carry with you when you're going for your appointments. Yeah, and then we have, information about why you should consider a clinical trial, some information about Medicare coverage as well. And then I also want to share the fact sheet about Torey's information that he shared earlier today. So this, compiled everything in a fact sheet. So if you are a patient who's using Optune Gio, Torey has, shared a good list of all the tips for wearing Optune Gio device and like for when to switch and some of the good tips that he has, figured out in his 4 years while he was using the device. So if you are a patient who uses Optune Gio device, I think this would be a good resource for you as well to just have this and like reference it when you are changing the device or arrays. Yeah, just to have it handy at your home as well. And then I also want to share one more thing with you guys. So I will share my contact information in the chat as well. And then you saw my contact information in the slide before. But we also have this patient inquiry form, which you guys can fill out. It's very simple, very short form. It just has name, contact information, and then you just share what you are looking for, what assistance you are looking for. And then I will reach out to you. I just want to emphasize that please, when you are sharing your contact information, make sure it's a good contact information and active contact information, active in a sense that you regularly use that phone number or email address, because sometimes when I reach out to patients, they provide an email address that's maybe old or that's not monitored every day. So I'm not able to reach out to them, or I'm not getting a response back from them. We do not sell your contact information. This is just so I can reach out to you to set up time to, set a one-on-one meeting so we can discuss what assistance you need, how I can help you, or what are some of the things I can assist you with. So this is the form, and then I will share my contact information in the chat as well. So yeah, please let me know if you have any questions, or just reach out to me, call, text me, or email. I'm happy to talk to anyone who's reaching out to me.
Thank you,
Thank
Shreya.
you.
Thank you,
Yeah.
Shreya. Thank you so very much. Shreya works nationally with all kinds of patients and families and caregivers. And from time to time, we do work internationally as well. And our National Patient Services and Support Center is actually located in Redmond, Washington, very close to Seattle, Washington. So, and we do take in-person appointments as well. We do Zoom all the time. We do phone all the time. We do email all the time, text lots, but you literally can set an appointment and come into our patient services center as well in person. So just so you know that. Jenny volunteers for the In Brain Cancer Initiative in the advancement area. So she's advancing patient education and she's advancing awareness related to the In Brain Cancer Initiative. I know Jenny is standing by. Jenny does have her own story, and she's welcome to share as much of that story that she wants to. But she also wants to talk to you today and share with you EBCI's bookshop. Jenny, it's your turn.
All right, great. Hi, I'm Jenny. Thank you for the introduction, Delanne. What a great video that Peter shared there. My heart's feeling tender. I wanted to just jump on to put in a plug for the EBCI bookshop. It's a little known resource, but one of my favorites. When my dad was diagnosed with GBM back in 2017, the diagnosis dropped like a bomb in our lives, as many of you know. And I wanted to learn everything I possibly could about brain cancer as quickly as I possibly could. So we did all the things, second, third, fourth opinions, reached out to EBCI, attended webinars, support groups. And I also wanted to read. As a voracious reader my whole life, it came very naturally to me to just want to read everything I could get my hands on. So I read clinical trials and research articles and blogs. But I also really wanted to read memoirs and other books about living with life-limiting illness. So I searched those out. I quickly found that there wasn't a really good curated list of brain cancer related books. So fast forward many years and we have put one together that's now housed on the EBCI website. And Shreya, if you want to just help me real quick to point it out, it's a little bit tucked away. There's so much good information on the website. that you got to dig a little bit to get to it. If you just navigate to our homepage and go to resources, and it's the third one down there, End Brain Cancer Bookshop, and it's also accessible on our app. So not only is it a very carefully curated, thoughtfully curated list of books, both memoirs, books for kids, grief, living with life-limiting illness, it also is hosted through bookshop.org, which some of you may know about. It is an incredible organization that allows for the proceeds of each sale, some of those proceeds, to come back to our organization. So while you are educating yourself and getting access to this incredible list, you're also supporting us by purchasing through our own bookshop, which again, it's listed on our website under resources, and you can also access it on our app. And on the app, if you're an app user, you're familiar with the various tabs there on the home screen. There's one that says EBCI Bookshop. And I want to put in a plug. If you, Sheree, wouldn't mind going back to our bookshop, there is a book here that is extra special under personal memoirs. It is a book by a young woman named Courtney Burnett. There it is, Difficult Gifts. Courtney Burnett was a young physician a few years ago studying medicine in Thailand when she began to have suspicious symptoms. And I won't give it all away, but turns out she has GBM. She wrote this incredible book, and she is also going to be the keynote speaker at our upcoming, I wrote down the name of the event. It's the Caregiver Self-Care and Tools webinar, which is going to be on August 1st. So if you have the opportunity between now and then to jump on our bookshop, order Courtney's book, and then attend the event, you will be in for an just sharing in her incredible story. And it is a story of hope. Courtney is a powerhouse. She has a blog. She has really taken this diagnosis in her life and made it her mission to connect with patients, caregivers, physicians. She's in that unique perspective offers a unique perspective as a physician herself, being able to create that bridge between the medical community and people actually going through this diagnosis. So check out her book. I encourage you to order it from our bookshop and attend our event on August 1st. If you have any questions, let us know. You can put them in the chat. If you have book recommendations, we would love to hear them. It's easy for us to jump on and add books. If you have a personal book recommendation that you've read and you want to include some comments about it, you can include those as well. And yeah, I think that's everything. Thank you.
Jenny, thank you so much. So if you do have a recommendation for a book, you can email Jenny, JENNIE, at endbraincancer.org and let her know what your thoughts are and what the book is and why it speaks to you. She would be happy to add that to our book shop. Thank you so much, Jenny. Really appreciate it. I wanted just really quick, since Jenny was talking about Courtney and our 2025 Caregiver Self-Care and Tools webinar series 1, it will be on August 1st, and registration is open for it. It is free, and the registration URL is right there in front of you. Courtney is going to be talking about how as a caregiver, you talk to your loved one's physician about not only the patient's needs, your loved one's needs, but how do you talk about your own needs as a caregiver to the healthcare provider and the physicians. She's got some really great tools and tips. And of course, she's extremely experienced in this area, being a physician herself, but of course, living and thriving with GBM. So we're delighted that Courtney has agreed to be our keynote speaker for this upcoming event. And I invite all of you to attend. Thank you so much. Let's see. I think I want to thank our awesome corporate sponsors and individual donors for this event today. It truly, the more dollars we bring in, the bigger the distribution of this kind of event can be as far as getting it out there but also the distribution of all of the presentations. We turn those into videos, and those are widely distributed globally all over. And the more resources we have, of course, the bigger the metrics can be and the more distribution can happen and the more education that happens because of that, which increases patient access. So again, thank you to our presenting sponsors today, Telix and Novacure. You guys are rocking the world in the GBM space. I want to thank you for your dedication and research in this space. Also, I want to thank our supporting sponsors and in-kind sponsors today: Great Purpose Productions, Integra, WIM Social, UCSF, Oxford Health, and again, that's in New Orleans, Louisiana. I don't know them very well, but I'm going to learn about them some more. And the Preston Robert Tisch Brain Tumor Center at Duke. And again, a special thank you to Novacure for over a decade supporting our National Hope Award, Patient Disease Education Awareness and Outreach, and the actual programming and the actual award. So thank you so much. If you're, a business owner or industry, pharma, device, diagnostic, we're always seeking corporate sponsors for all of our events, all of our programs, all of our services. So just know that. Feel free to contact me if you're interested in discussing. And, with that, I want to say thank yous to all of you for your support of the End Brain Cancer Initiative and our mission. And I want to say thank you to all of you for attending today. I just want to thank you for the way you are fighting this disease. You're showing others how to do it. And so thank you for helping others as you continue to walk with this disease. And just thanks for joining us. And we're here to support you in any way that we possibly can. Thank you, everyone.